Good afternoon, and welcome everyone to the Senate Committee on Health and Human Services for the 83rd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang. Senator Stone. Senator Taylor. Senator Titus. Chair Doniate.
And I'm here. All members are present. Good afternoon, and thank you so much, everyone, for joining us today. Today, we do have 5 bill hearings that will be scheduled for this evening. We have Senate Bills 234, 187, 330, 390, and 378. Not in that order. I will share with you the order in just a second. Please note that this meeting is flexible because of the magnitude of what we're going to be talking about today. And agenda items may be taken in a different order than listed, or 2 more agenda items may be combined for consideration. The schedule that I have so far for these bill hearings are, we're going to go ahead and do Senate Bill 234 first, and then followed by that, we will do Senate Bill 187, and then we'll do Senate Bill 390. Senate Bill 330 will be right after that, and then the last one on the agenda is 378. So that way folks can leave if they want to come back and so forth, but hopefully that gives room to understand the order of business today. For those that are looking to testify, please go ahead and sign in at the table by the door and provide a business card to the committee secretary. If you do not wish to testify today, we still ask for folks to please sign in so that there's a record of who is interested in that particular bill. And in the event the committee needs to contact you later. When testifying, we ask for folks to please turn the microphones on to speak and off to listen. And we have listeners and viewers in Las Vegas and online and are recording this meeting, as it will be available on the legislature's website. We also ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated and we can get through the agenda in a timely fashion. And speakers are urged to avoid repetition of comments made by previous speakers. And lastly, we ask for folks to turn off their electronic devices, especially their cell phones, or put them on silent mode during the meeting. More on the protocol, because we have such an extensive, we have a deadline coming next week, and because we have many bills to go through today, every bill will have a 15-15-15 breakdown. So similar to how we did it on Tuesday and last week, there will be 15 minutes allocated in support, 15 minutes in opposition, and then 15 minutes in neutral. And so we ask for folks to, we want to get as many individuals to participate. And so it's okay to say ditto. It's okay to not do the full 2-minute remarks, because you can always send it in writing and we can circulate that to the members. And so that's the bill order for today. And so I'm going to go ahead and pass it on now to my vice chair to start the hearing on Senate Bill 234.
Thank you, Mr. Chairman. Okay, we will now open the hearing for Senate Bill 234 and ask our chair and co-presenters with him to please come forward at this time. And if anyone's helping to present in Las Vegas, we'll ask them to come forward at this time too. For presenters only. And I do now. And Mr. Chairman, please begin whenever you are ready.
Thank you, Vice Chair, and good afternoon to the members of the Senate Committee on Health and Human Services. For the record, I am Fabian Doniate, and I represent Senate District 10 in Las Vegas. Today, I'm here to speak on Ruby's Law, a bill that addresses critical gaps in Nevada's Medicaid emergency coverage, ensuring timely and appropriate care for individuals with cancer. I am joined today by Ruby, who is joining us virtually, Katia, who is going to be in Las Vegas, and then, of course, Annette, who is here right next to me here in Carson City. A little bit about my co-presenters for today. Ruby, who is virtually, is a formerly undocumented cancer patient who is now a U.S. citizen. She was brought to the United States as a toddler and lives here in Nevada. She was diagnosed with cancer and is here to tell her story. And Andrea, who is joining us online to answer any questions, she has served as Ruby's caseworker that helped her family through this diagnosis. Katia, who is joining us from Las Vegas, is also a cancer survivor. And of course, we know Annette from her work as a founder of Cure for the Kids. I'm going to let Leticia, my intern, present the bill and the contents of it, and then she'll turn it over to me when we go more into the specifics.
Good afternoon, members of the Senate Committee on Health and Human Services. Madam Vice Chair, thank you so much for giving me an opportunity to present today. My name is Leticia Delgado. That's Leticia Delgado. And today we're going to dive into the key aspects of billing for medical emergencies, explore emergency Medicaid workflows, and examine relevant case studies. We'll also review some national trends, including landmark policies in Minnesota's Emergency Medical Assistance Program, and after analyzing local data and potential cost savings, we'll highlight the provisions of Senate Bill 234, or Ruby's Law. So let's go ahead and begin. In 1986, EMTALA, or the Emergency Medical Treatment and Labor Act, was established to ensure that hospitals provided emergency care to anyone who needs it. Under EMTALA, hospitals are required to treat and stabilize anyone who comes into the emergency room with an emergency medical condition. They cannot be refused care because of the patient's ability to pay, their immigration status, or insurance coverage. For the first time, hospitals could get reimbursed for emergency medical care given to low-income individuals who would otherwise qualify for Medicaid but do not meet the current requirements. Later, the Omnibus Budget Reconciliation Act of 1988 formally allowed hospitals to bill Medicaid for emergency services provided to immigrants regardless of their immigration status and other non-citizens who do not qualify for full Medicaid benefits. In essence, it created the Emergency Medicaid Program. This program required states to provide Medicaid coverage for life-threatening emergencies, including emergency labor and delivery for pregnant women, severe trauma or injuries requiring immediate care, and acute conditions like heart attacks, strokes, or kidney failure requiring dialysis. It really demonstrated Congress's commitment to reimbursing for life-saving care. The federal criteria for the state's emergency Medicaid eligibility is based on income, residence, and medical condition. This determination of whether a condition qualifies for EM is made by a medical provider and is documented in the patient's hospital records. But overall, these are the three conditions that must be met for EM to be triggered for the existing procedures. There should be the fact that a lack of treatment would place the patient's health in serious jeopardy. It would place the patient at risk for serious impairment of bodily functions, or it would cause serious dysfunction of any bodily organ or body part. We know that timely care significantly enhances healthcare outcomes. It reduces complications, and it facilitates early diagnoses of chronic conditions. However, its full potential remains unrealized due to the restrictive definition of emergency in the current statute. This limitation has severe consequences. For example, emergency-only hemodialysis is associated with higher hospitalization rates, increased mortality, and costs that are 4 times higher than the standard treatment. Recognizing this gap, the Minnesota Legislature expanded the Emergency Medical Assistance Program to cover critical services, including dialysis for kidney failure, cancer treatment, and kidney transplants. Now, with the background of emergency Medicaid outline, I want to walk you guys through the typical workflow of an emergency Medicaid case. First, a patient arrives at an emergency department. Due to a severe medical condition. This could include labor, heart attack, or trauma. The hospital, under EMTALA, is required to provide a medical screening exam regardless of insurance or immigration status. Then, a doctor assesses whether the condition qualifies as an emergency medical condition, the risk of serious harm, severe pain, or life-threatening situations, and if it qualifies, the hospital proceeds with stabilization and treatment. If the condition is not an emergency, the patient may be discharged or referred to another provider. When it is an emergency, the patient is screened for financial eligibility based on income level, residency, medical necessity, and immigration status. The hospital submits an emergency Medicaid application to the state Medicaid agency, and it includes documents like identification, proof of residency, and hospital records that confirm this emergency. After review, if it's approved, Medicaid reimburses the hospital for emergency care only. The patient is then discharged, and they get instructions for follow-up care, but this care is not covered, and there's no current coverage available for it. So I am now going to pass it over to Senator Doñate to sort of give us a more local insight into this.
Thank you so much, Leticia. So the process that Leticia is breaking down is essentially individuals, because of EMTALA requires us to cover everyone, right? Individuals are coming to the ER, they're being treated for their emergency situation, and then before they are discharged, If they qualify, the hospital will help that patient essentially submit the application so that the hospital can recoup the costs for the care that they delivered. So that's the program that we're talking about. I wanted to dig deeper into who are these patients that are going through these facilities that we already have to reimburse, that we're not reimbursing, but they're going through the facility anyways. And so the data that I have provided from Sunrise Children's Hospital in Las Vegas breaks it down between inpatient and outpatient situations, adults and pediatrics. In the following slide, you will see, if you can go to the next one. Excuse me. We wanted to specifically dive into the pediatric cases and the comorbidities that they are being diagnosed with. And so on this slide, you can see what are they coming from. They're coming for respiratory infections. They're coming for seizures, right? And so these are the types of cases that we differentiated that would be considered serious to life-threatening. Now, we also broke it down to see what are the other types of cases that are coming in through the hospital system. And so you can see there are some that are defined as complications, right, that do not elevate to the level of severity. And then the last one is just others that are exhaustive, so psychosis, right, patients that are coming into the hospital for these diagnoses. We're treating them, and then the question then becomes the loophole that I will explain as to what happens afterwards they get treated. And so I want to go through this case study because we're going to talk to you about stories that are actually happening in the community and how SB 234 would help. So let's start with, the workflow only told us one part of the story, but I want to use this case study as an example of a situation that we may encounter. So let's examine the case of Mateo. Mateo is an immigrant, a 16-year-old living in Southern Nevada. Mateo's family rushed him to the ER because he couldn't stop coughing. And so he had a lot of unusual bruising and he ran a fever and just could not breathe. He comes to the hospital, right? Whether it's Sunrise Children's Hospital or UMC. After some blood work, right, the care team diagnosed him with leukemia. In a matter of hours, Mateo went from being a normal teenage boy with a stubborn cough to now a patient with a life-threatening cancer diagnosis. At that point in time, the hospital would help him apply for emergency Medicaid, which would cover his ER visit, diagnostic tests, transfusions, and the immediate hospitalization to stabilize Mateo while he's at the hospital. After he's quote-unquote stabilized, right, Mateo will go ahead and receive a follow-up instructions consisting of chemotherapy recommendations and long-term cancer treatment. Despite having a brutal, rapidly evolving cancer, the narrow definition of emergency means that chemotherapy and other follow-ups are not covered. And so Mateo, in this instance, will have to be able to receive treatment from the emergency department, but it's not until he experiences organ failure or severe infections that emergency Medicaid would be triggered again. So the instance that we're seeing with Mateo is qualifying for emergency Medicaid. He does qualify based on the eligibility for it, but in order for him to retrieve it, he has to go back into the emergency room because that is where he would be considered as life-threatening. But if you are, say, a cancer patient or someone with a terminal disease, right, just because you're stabilized, when you leave the facility, if you do not receive your treatment, once you have been deemed to have a life-threatening diagnosis, you're going to go back into the emergency room again. If not, it's going to be an even worse scenario because now we're delaying the treatment for that terminal or life-threatening diagnosis. And so for a standard risk, go back. We actually did the math in terms of what these cases traditionally cost. So for a standard risk acute lymphoblastic leukemia diagnosis, the most common type of childhood cancer, treatment costs in Nevada could vary significantly by age. And so for a 16-year-old like Mateo's, treatment would likely cost around $695,000. That is the data that we were able to work with Cure for the Kids to verify what the average treatment cost would cost for a family. However, this doesn't have to be the case. As legislators, we have an opportunity to significantly reduce health expenditures by enabling providers to care for Mateo in an outpatient setting. So in this chart, we are comparing the treatment components of SB 234, having patients go through an outpatient oncology treatment center versus getting their oncology treatments in the ER, which is the current status quo. So if you look, obviously, I think we all know that hospital care is usually just more expensive, right? There's more requirements. It's easier and more affordable to have someone get treated at the outpatient care level setting. And so you can see the breakdown that we did between the two numbers of what it would take to have someone go through treatment through an outpatient oncology scenario versus the billing of an emergency room. These numbers, we compared it actually with several providers in Las Vegas, and they gave us that this is a fair assessment in terms of what the cost of treatment would look like at the ground level. And so on the next slide, I want to go more into deep on the billing considerations for a type of provider or if we were going through the scenario. So in this particular slide, as you can see, right, this is a one-time hospital encounter for a patient that was billed under the DRG code 839, which is the acute lymphoblastic leukemia diagnosis. And so you can see that there's a hospital admission and the CPT code that is affiliated with that, right? There's the diagnoses tests and so forth. And so as you drill down, right, the average cost or estimated cost for one visit would be around $15,000. That's just for one time going into the hospital to get your cancer treatment. Now, we did the same comparison with what it would be to do that one-time encounter at the outpatient clinic level, and you can see that because you don't have to pay room and board and you don't have to be taken in as an inpatient to receive the care that you need, now what we're doing is we're reducing the expenditures that ultimately still would provide the level of treatment for the patient, but reduce the burden of what taxpayers ultimately have to pay for back, right? So regardless if we disagree whether or not these individuals should be receiving this care or not receiving this care, the fact of the matter is they're receiving the care at some point, and they are qualifying for emergency Medicaid. That is true. So there's this belief that we're expanding eligibility, we're doing other services. That's not true. These patients already qualify for emergency Medicaid. The difference is that their emergency Medicaid expires once they leave the facility, and they're still in a very, very critical scenario where they will probably more than likely return back to the emergency room. And so in this slide, obviously, pre-SB 234, we can see that the likely scenario beforehand was for Mateo's case study, he would not have the ability to continue on his emergency Medicaid to receive his life-saving treatment to prevent the readmission back to the ER where he would have to return to get his medical treatment for his cancer diagnosis. But with SB 234, we're specifically looking at the life-threatening cases that are finding themselves in that loophole where they are qualifying for emergency Medicaid. The hospital is billing for emergency Medicaid, and now we just want to continue that so that they don't have to keep going through the emergency room to get their treatment. And then last but not least, I think that ultimately, right, as legislators, we want to make sure that there's a cost savings that can be conducted to it. And in this scenario that we've worked with Cure for the Kids, there is a potential cost savings that could be adjusted because, I mean, theoretically, if we're reducing the amount of people that are coming back through the ER and can get their care somewhere else, there's ultimately going to be a cost savings with that just on the basis of principle. And so that's what we're trying to do specifically for the kids below a certain age threshold that have been diagnosed with the most critical and egregious cases that we're seeing in the market and in the state. And so that's why we're hoping that there is some level of clarity that can allow these patients to receive the continuity of care that they already were eligible for, and we're trying to solve the loophole that they're experiencing. And then, next slide, please. Ultimately, right, Ruby's Law, as we described, would help now cover emergency medical transportation, emergency room care, and in-person services related to emergency medical treatment for individuals 21 and below. There is an amendment that I believe is, I think you guys have a printout of it, and it's also on Nellis, that this bill only applies to individuals below the age of 21. So we're only talking about children that have been diagnosed with cancer for this bill. It will provide limited coverage for renal disease or cancer treatment if approved by the department based on medical necessity. It would allow for the limited coverage of continuing care in a skilled nursing facility for patients that are going towards end of life care. And it would require the department, of course, to administer the provisions consistently with other Medicaid rules. So we went through the semantics of the bill, but I think it's important, as always, to hear from the stories directly impacted. And so I'd like to go ahead and let Ruby talk first about her story.
Hello. You guys can hear me perfectly?
Please proceed.
Perfect. Hello, good afternoon. My name is Ruby. I'm a resident of Las Vegas and a childhood cancer survivor. I'm with you today to share my story and the importance of children having access to life-saving care and treatment, no matter their status in our country. I was first diagnosed at the age of 6 when I was with a cancer in my liver. I don't remember all the details. They were, tough to remember at such a young age, but I remember all the feelings vividly. I remember my tumor being so big that I looked pregnant and I couldn't sit upright, and the pain was unbearable. I was rushed into the ER at UMC where the scans revealed a very large tumor in my abdomen. My follow-up care included a misdiagnosis from an oncologist who said they couldn't operate on the tumor. Despite how big and invasive the tumor was, my biggest challenge was being undocumented. At the age of 6, it was hard to comprehend because I didn't ask for any of this, and now I imagine the pressure and burden placed on my family. My status made getting treatment nearly impossible. Being undocumented meant having no means to pay for treatment. I wasn't eligible for Medicaid, only emergency Medicaid. I ensured the hospital got paid something. This meant no fighting chance to survive the cancer that was taking over my body. My life depended to have access on Medicaid. Thanks to the help of the social work advocate and my mom, I became a resident and was able to get on Medicaid, and treatment began right away. I was flown to Los Angeles Children's Hospital for surgery. My tumor was over 40 pounds at that point and larger than a basketball. After surgery, I was placed into a medically induced coma so that my body could recover. After that, I returned to Nevada and I underwent a very aggressive chemotherapy, which lasted 3 years. I was about to hit my 5-year mark on being in remission when the cancer returned. This time in my lungs. I returned to treatment for 2 years, but suffered complications, including damage to my other organs, which I still struggle with some of those today. Shortly after my second fight with cancer, my world changed once again. My mother was diagnosed with stage 4 breast cancer while she was pregnant with my sister. She was undocumented and had no means to pay for treatment. She didn't qualify for Medicaid or any type of quality insurance. Therefore, she was not able to get the treatment she needed to survive. I remember feeling hopeless and not being able to help. All I could do was help take care of my sisters, make sure that she would eat and she was as comfortable as possible. It pained me to watch my mother slowly fade away and not be able to do anything. I remember my last conversation with her. I will never forget it. My mother was my hero and still is my hero. Having access to Medicaid played a vital role in why I beat cancer. And my parents and social workers fought for me when I couldn't. They were my voice when I was too young. Today, I'm fighting for the children who need a voice. My outcome could have been much different. Unfortunately, for many children who are sick, their outcome aren't as positive. and this shouldn't be the case. It's not the matter of politics. This is about saving the lives of the children. In 2002, I officially became a U.S. citizen, and the process started around the time I was first diagnosed with cancer, and it took almost 15 years to complete. My status shouldn't have determined my outcome in treatment, and this needs to change. The power is in the hands of our lawmakers, and I hope you do the right thing. Thank you.
Thank you so much, Ruby, for sharing your story. Vice Chair, I'd like to go ahead and let Katia from Las Vegas share her story if it's okay, and then we'll let Annette speak.
Okay, go ahead, Chair. We're at 21 minutes, sir. All right.
Hello, my name is Katia. In 2015, at just 19 years old, I was diagnosed with thyroid cancer. I wasn't a U.S. citizen, but I had a DACA work permit, which allowed me to be employed. At the time, I was a full-time student, part-time teacher, and part-time tutor. But because I didn't have one full-time job, I wasn't eligible for employer-provided health insurance. When I received my diagnosis, my doctors told me they could likely remove the entire cancerous mass with one single surgery. However, to access that treatment, the hospital required me to pay around $15,000 up front, just to cover about half of the cost of the surgery. That amount didn't include the blood work, scans, biopsies, and other tests I had already undergone. I had no idea how to come up with that kind of money. My family certainly did not have it. It was the first time someone in my family had faced that serious medical issue in the US, and we had no idea where to turn. I sought advice from anyone who might have a solution. Eventually, someone suggested I apply for emergency Medicaid. I was hesitant because of my status, but desperation pushed me to make the appointment and apply. Later on, Medicaid called, and they denied my request. They told me that the type of cancer that I had wasn't considered an emergency. I was shocked. I was still a teenager, and this was the first time I realized how apathetic our medical system could be. It went against everything that had been taught to believe. Thankfully, my community stepped up. I started a fundraiser, and donations came in. My uncles organized a car wash. My aunts organized a kermés selling food to support me, and local news outlets shared my fundraiser link, and so did community leaders. Las Vegas came through to help one of its own, and for that I will always be grateful, but it was still a devastating time. Even with all the money we raised, I was still short. My family sold our belongings, worked extra shifts, and borrowed money to cover the remaining costs. I continued working through my illness, and less than 2 weeks after my surgery, I was back at work. I was afraid of losing my job and my income. No matter how sick I felt, I showed up to work and school because I couldn't afford not to. The debt was piling up, and the financial strain weighed heavily both on me and my family. In 2016, I was declared cancer-free. Many people hear my story and they call it inspirational, but I don't want that. It's not a story of triumph. It just reminds me of a dark time when I was sick and denied care. A time where I felt like a burden to my family, and when hundreds of struggling people, many of whom barely had enough for themselves, gave what little they could to help me survive. This is not how things should be.
Thank you, Katia, for sharing your story. Vice Chair, for the sake of time, I think Annette will do her remarks during the testimony, but we're ready to answer questions, and so she'll be here just to answer questions as well.
Okay, thank you, Mr. Chairman. Just trying to follow your lead in this. We do thank you for sharing your stories, and I know you're prepared to share yours in Las Vegas and even here. We will turn now to the committee members for any questions for the Vice Chair or other presenters. I see Senator Stone. Please go ahead.
Thank you, Madam Vice Chair, and thank you very much, Senator, for the stories, and to Tatia and Ruby. I'm very pleased that you're in remission. I hope you remain in remission. We have a country that has a $36 trillion national debt. And the most expensive part of our federal budget is entitlement programs, of which Medicaid is one. So how does this bill ensure that the healthcare needs of Nevada citizens are prioritized when extending coverage to non-citizens? Is my first question.
Thank you so much, Senator Stone, for that question. So that's, I want to go back to the provisions. I'll talk about the cost in just a little bit of a second, because luckily I prepared this time compared to last session about that question. Mm-hmm. The difference between this presentation versus the previous conversations is when EMTALA was passed in 1986, right? Congress, right, the United States came together and says, we cannot deny individuals life-saving treatment of care, regardless of who they are. But the difficulty that came was that there was a financial burden that existed also for these hospital systems. And so in 1986, Congress came together and said, we are going to establish the provisions of emergency Medicaid, because through emergency Medicaid, the hospitals will have the ability, if they meet the three conditions, which is it's life-threatening, it leads to the deterioration of bodily functions, and then from there, right, if there's some level of severity and acuity that would rise, then the hospital will be able to build back. Ultimately, right, the costs that they are not able to recoup still rely back on the taxpayers, because ultimately they have to write off, they write off the costs. And so this fallacy that, or this argument that we are subsidizing the care for non-citizens is just truly false, because in some way, shape, or form, someone has to pay that responsibility. Congress decided at that point in time that hospitals should have the ability to build back Medicaids. And so that's the first thing that we're talking about specifically. And the other provision, I know this is not a fiscal committee, but I think we have to remember that these are individuals that oftentimes perhaps are here to a legal extent, right? Katya, who's a perfect example, has DACA, right? She is here in what we consider to be legally, but she did not qualify. She does not. DACA recipients do not qualify for emergency Medicaid, and so unless if they qualify in that scenario where they're going to the emergency room, in her case, qualifying because of a life-threatening illness, but as soon as she leaves, that's where the termination begins, and so it's not a question as to whether or not they're here legally. It's a loophole that we're seeing where patients are qualifying, and we cut them off as soon as they leave the facility, when even though they have been deemed to have a life-threatening illness. And so all I'm asking is for those specific scenarios, for those children that are in that situation, that instead of having them be rerouted back, which the taxpayers have to pay for anyways, it makes sense to have them rerouted to an outpatient facility so that it reduces the burden of what we already have to do based on what EMTALA and Congress has ruled to be as a rule of the land.
I understand the economic argument that you're making, and I understand that this program is quite abbreviated in respect to the programs that exist to our neighbor to the west. But you're talking about some very expensive treatments. Not to say that these lives aren't worth money; they are. But we see in our neighboring state that through the approval of providing medical benefits to undocumented residents, the state of California is in a financial crisis where they have to borrow tens of billions of dollars just to take care of their Medicaid obligations. And so can you talk about how this just might not just be the opening of the door to following the example of, I'll say, California, that has got fiscal problems because they don't have enough money to provide services for their lawful residents, let alone undocumented residents? How do we follow that example?
Thank you, Senator Stone. Fabian Oñate for the record. I would specifically reference to you that all we're talking about in this proposal, and my commitment is to this proposal of solving the loophole. If there's a conversation in terms of the fiscal applicability of this, I would remind you that there are several senators on this committee that have fiscal notes that are way larger, as you may probably can attest to that. And this bill is significantly shorter than what we're talking about specifically for these children. The fiscal note, again, referencing that this is not a fiscal committee, the fiscal note now only applies to individuals below the age of 21, so we're only talking about maybe 10 to 30 children statewide. It's a very, 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 very low number in terms of who would be applied. But again, it's because of that circumstance of we're going to have to cover anyways their return back to the hospital system. We should find a way to ease the burden that taxpayers are ultimately on the hook for anyways, so that it eases not just the quality of care that these individuals are going for, but also the funds that we have to pay back for if they return back to the emergency room with an even more critical illness, had we just taken care of them from the very beginning. So that's where the applicability of the financial circumstance comes from.
Okay, and then if I get one more question, and I'm done. So Medicaid is a state federal partnership. And so assuming the bill gets passed and signed into law, we still have to apply for a federal waiver. Do you think that the atmosphere in Washington, D.C. today is conducive to granting us an approval for a federal waiver under these circumstances?
Thank you, Senator Stone. Fabian Duñate for the record. These provisions specifically deal with only on the types of benefits that Medicaid recipients would receive. I am not going to speak in terms of the applicability of what the federal government would or would not do, because that's not my responsibility. My responsibility is to respond to the needs of the state and the residents of this state, and this is one of them.
Thank you, Senator Stone. Other questions? I was going to say Dr. Titus. Senator Titus.
Thank you, Madam Vice Chair. Senator Donate, thank you for being here and your presenters and the testimony. I appreciate your passion for who you represent and the care that folks need. I wish it was limited to the folks that you've identified, but it's an issue of cost of health care for everybody, not just a select group. So having said that, I want to specifically address the bill and a couple of the comments that were made. And in section 1 on page 2 of the bill, number 4, it mandates that our state Medicaid department will apply for any waiver, federal law, apply for any amendment to the state plan. How many, other than the California reference, do you know how many states have done this and applied for this waiver? And if so, were they granted? And if so, how long did it take for them to get the waiver?
Thank you. Are you referring now to the provisions, just to Fabian Duñate for the record, you're asking in terms of what are the types of programs that different states have done specifically for children and so forth?
To waiver the emergency medical treatment. Past that initial EMTALA, we have to take care of it.
Yes. This legislation specifically was taken from what Minnesota already has codified in state law. That is where we took it from. Other states have expanded on beyond further in terms of what types of treatment they give to all children, right? So Utah is one of most of the recent examples where they have expanded essentially a program where they are outlining dollars. Those dollars can go to any children regardless of their immigration status and so forth. That is not this proposal. This proposal is mimicked after Minnesota, where it allows the flexibility from the department to determine as to whether or not they could reduce the expenditures, because ultimately, if there are those egregious cases, we can continue their treatment so that we don't have to get them in the emergency room. So the
2 states that you've identified, Utah has it and Minnesota has passed it, and we know California has.
California, Oregon, Illinois. I don't know if I said Colorado yet. Colorado. So there's several states that have implemented some version of it, with Utah being the most recent.
So the template is that the waiver application has been supported when applied to the federal government for this waiver. So there is some precedent for this being accepted.
Fabian Duñate for the record, correct. This is already codified and implemented in Minnesota, and it is working the same. That is the same way that we would like to have this directly work, the same way.
A follow-up on that, Madam Chair? So just in the process, and I absolutely agree that we have to, by mandate, emergency rooms. Even my clinic, if somebody walks into that, it doesn't matter. I don't check whether, I speak reasonable medical Spanish, and who walk in my clinic, I'm going to take care of you, regardless based on your need, not regardless of where you're from or and how you got here, whatever. If you walk into my clinic or walk into the ER, we're going to take care of you. We're mandated to do it, and it's just the right thing to do anyway. But that follow-up services is a thing that have me concerned in listing in this bill. Certainly, when you list on the ones about the end-stage renal disease and potential transplant, certainly those are not, and you may need emergent dialysis if you walk in undiagnosed with renal failure. That may be something you immediately have to have. But the transplant actually is something that you have to do a lot of research on. Obviously, you have to have somebody that matches, and it's not like an emergent, we're going to do it today. Was those plans okayed on other states as an emergency plan?
Thank you, Fabian Oñate, for the record. Correct. This is what Minnesota has already implemented. And I just want to remind the committee that we actually already offer dialysis that was passed by the Nevada Legislature already before to be covered under emergency Medicaid. So individuals do have the ability to get that, but you don't get cancer treatment as part of this in this scenario. So and again, I want to reference that the issue that we experience with the patients is that they did qualify for emergency Medicaid, but it left as soon as they left the facility.
Right, so exactly right. So it does, there's no doubt in my mind that emergency care is more expensive than certainly preventive care, outpatient treatment care, et cetera. Again, just as a statement, the understanding is that, yes, it's expensive, but there are hundreds of thousands of folks in Nevadans that can't afford the care that they're receiving, even though they might have insurance, et cetera. So again, this isn't a fiscal committee. We will see this in the fiscal committee, but the concern about cost. But I certainly appreciate you bringing it forward, and you're representing folks that certainly have a need. So thank you, Madam Chair, for the questions.
Thank you, Senator Titus. Other questions? Yep, Senator Lang?
Senator, so we just passed that bill out of the Senate this morning about kidney transplants and care for end-stage renal failure. Would that bill cover this part of your bill? Does it cover children?
Thank you so much, Fabian Oñate, for the record. My understanding is that these provisions specifically cover individuals that are under emergency Medicaid. I think the semantics of that is probably something that Eric can answer, and I believe Medicaid is also in the room. So, but this is my understanding, a different type of program. So, and we wanted to mimic. I just wanted to make sure that this is clarified. The services that are under these provisions and in my amendment are already covered in Medicaid. So we are just extending that to be in certain most critical scenarios to be also offered in emergency Medicaid, which is specifically the chemotherapy portion.
Thank you, Senator. I do have a question, just a clarifying question, and then also just a statement. And I think my colleague, Senator Titus, mentioned this, is we certainly understand how much more expensive emergency care is. I had to go recently and got the bill the other day, and I'm like, geez, I was there like 30 minutes. Shoot. Right. It cost me, I was going to say, cost me a week's salary here, but that's not saying much. But anyway. But yeah, so certainly, and so I'm interested in that. When you go back to the slide, you had some numbers up there that talked about the differences if we're paying for this in an emergent fashion versus if people continue to come back. Kind of talk us through. We don't have that. I don't think any of us. So can you talk us through that just a little bit in terms of the comparison?
Sure, Fabian Oñate, for the record. So what I wanted to do in this scenario is the experiences that Ruby and Katia were able to share with you they had to go to the emergency room to receive their care and treatment, right? They could receive it here in Las Vegas, or they had to go to another state to receive the life-saving care and treatment. And so what we have put together in this scenario is, traditionally, for your visit and your diagnosis, what would it cost to maintain someone with a acute lymphoblastic leukemia diagnosis? And so that's what the comparison is. So obviously, there's more if a patient is admitted to be an inpatient versus an outpatient setting, right? Now you have to pay room and board. You have to pay other expenses that you non-traditionally would not have to pay in an outpatient-based setting. And so that's kind of the differentiation that we've segmented in terms of what the estimated costs. Again, these costs I verified with local providers in the state. And so when I asked them, is this a fair reference point? They responded, yes, these are fair estimates based on the types of services that we provide and so forth. In the next slide, this actually breaks down to you that each encounter, right? If I was a cancer patient and I went to the emergency room, this is what it would cost me based on the CPT codes under the DRG, the Diagnosis Resource Group. that's essentially what we would charge each for the conditions that they're coming in for. And if you do the same thing but from an outpatient setting, now you see that it pretty much cuts each encounter in half, essentially. So again, we still have to, regardless of the person's immigration status, is whether we agree or disagree that they belong here or don't belong here, they're still coming to the emergency room for treatment. And we still have to, the taxpayers still have to pay for it because it's part of emergency Medicaid. The reduction that we're trying to advocate for is to close that loophole so that they can continue their treatment without having to go back to the ER, which ultimately costs significantly more and can ease the burden of access to care.
Thank you, Senator. I appreciate that. I certainly know how important, as a cancer survivor, right, being able to get that care, the kind of impact they can have. Other questions from the committee? Again, I want to thank your presenters, Katia and Ruby, for sharing your stories. That can't be easy to do at all. So what we will do, I know we have one of the presenters who will give our first public comment. We will ask now, Senator, if you and Ms. Delgado will please step back, if you would, so we can open it up for anyone who would like to testify in support of the Senate Bill 234, and we know we're going to go to you first, here in Carson City. And if there's anyone in Las Vegas who would like to testify in support, please come forward to that table at this time. We will have 15 minutes for support, 15 minutes for opposition, and 15 minutes for neutral. So we will start here in Carson City, do our first three, then we'll go to Las Vegas, and we'll go to the phone lines until our time is up. Remember, it's only 15 minutes total, so it's okay if we have a good ditto, so we can give as many people the opportunity as we can to share their thoughts. So please go right ahead when you're ready. Don't forget to state your name for the record.
Thank you. Annette Logan Parker, for the record, ANNETTELOGAN-PARKER. Based on the conversation that I just heard, I think it's important for us to remember that since 1986, things have dramatically changed in how childhood cancer is treated. 80% of all childhood cancer in today's clinical environment is routinely and appropriately treated in the outpatient environment. So I think it's important to recognize that. And so, we have children that come to us through an emergency room referral or a general pediatrician's referral who actually spend very little time in the hospital at all under today's current clinical structure. So I think that that's an important thing to take into consideration. And then, I think it's important to recognize that when a child is late to diagnosis, the cost of that care is going to be extremely higher than if we had early intervention. So what we have seen at Cure for the Kids is often patients come to us with end-stage disease, and then the treatment of that end-stage disease is astronomically higher, more clinically complicated, and then obviously doesn't have the same results, patient outcomes that we see every day now. I mean, we're curing childhood cancer in the outpatient environment every day. And so I know we're limited on time, so I do have a breakdown that I'll leave with about the cost savings for early outpatient pediatric cancer versus inpatient and delayed treatment that really provides a lot of information that I think you might find valuable. Thank you for your time.
Thank you so much. And if you would leave that with our committee staff, they'll make sure that we get it. Okay, please go right ahead, sir. State your name for the record.
My name is Maximilian Lowe, Maxmillian. My last name is Lowe, Lowe. I'm here in strong support of SB 234, which expands Medicaid coverage to individuals currently excluded due to immigration status. Healthcare is a basic human need, and ensuring access to essential service benefits not only individuals but at the entire community. Expanding coverage reduces uncompensated emergency care costs, improves public health, and ensures that all Nevadans, regardless of status, can receive preventative care rather than wait till a crisis. Many of those individuals are hardworking members of our communities, contributing to our economy and in society. Providing them access to health care is both a moral and practical decision. So I urge you to support 234. Thank you.
Thank you, Mr. Lowe. We'll take one more here in Carson City, and then we'll go to Las Vegas.
Vice Chair Taylor and members of the committee, Connor Kane on behalf of HCA Healthcare, which includes Sunrise Hospital and Sunrise Children's Hospital, here today in support of Senate Bill 234. And first, I'd like to join many of you in thanking Ruby and Kati for their very inspiring stories. Sunrise Hospital and Sunrise Children's Hospital is the state's largest acute care hospital at 834 beds, treating over 250,000 patients each year. Last year alone, nearly 190,000 patients came through the emergency department. Sunrise is also the state's largest safety net hospital and Medicaid provider. 1 in 5 Medicaid recipients in Nevada receive their hospital-based care at Sunrise, and 1 in 4 in Clark County receive their care at Sunrise. Emergency Medicaid applications are something dealt with frequently at Sunrise, particularly after a patient has presented to an emergency room with a serious condition. We want to thank Senator Iñate for continuing to work on this important issue and are in full support of Senate Bill 234. Thank you.
Thank you, Mr. King. We're going to go to Las Vegas now. We'll take 3 there, and if there's anyone else here, please fill up. We'll keep our round going. Please go ahead when you're ready. Our first speaker in Las Vegas.
Yes, hello. My name is Hernan Alvarez Sanchez, for the record, HERNANALVAREZ-SANCHEZ, and I am the Deputy Organizing Director for Make the Road Nevada, urging the members of this committee to support this bill. Thank you.
Thank you, Mr. Sanchez. Please, our next speaker, go right ahead when you're ready.
Good afternoon. My name is Claudia Clendenin, Claudia Clendenin, and I am a licensed social worker. A few years ago, a 10-year-old boy came into our clinic with a painful enlarged mass. He had had surgery 10 months prior, but with no follow-up care because he was uninsured and undocumented. As anticipated, without the required outpatient care, the mass returned. He was weak, losing weight, and experienced multiple fainting episodes. He was finally referred to C4K, and at his first visit, we could already see the uphill battle the family would face. Through Care for the Kids Foundation charity care program, we continued seeing him in our outpatient clinic, but our limited charity care doesn't cover hospitalizations, imaging, and labs, many of which he needed immediately. He was diagnosed with a malignant tumor that required aggressive therapy and surgery. His single mother, caring for 3 children, had to stop working. Even with nonprofit support, they were crushed by the out-of-pocket costs for scans, procedures, and pain relief. After 3 months of treatment, the tumor did not respond. The only option left was amputation. That emergency surgery alone cost hundreds of thousands of dollars and was finally covered by emergency Medicaid, but only because he was actively dying. Once discharged, he was back to navigating care without insurance. He couldn't get the follow-up scans to check if the cancer was gone. His prosthetic was delayed. Physical therapy was put on hold. Earlier access could have prevented a lot of this. Delaying care until a child is in crisis doesn't save money, it multiplies the cost. It leads to longer hospital stays, more complex procedures, and ultimately a far higher price for our healthcare system. SB 234 is our opportunity to do better by saving the state's limited Medicaid resources. Thank you.
Thank you so much. We'll take one more in Las Vegas, and then we'll go to the phone lines and come back here to Carson. Please go ahead when you're ready, speaker.
Hello, my name is Emmy Spottelson, EMISPOTLESON. I'm a licensed social worker, and I'm here in strong support for SB 234. This bill addresses a critical flaw in our healthcare system. Under current policy, undocumented children in Nevada are only eligible for emergency Medicaid once their disease is so far progressed and death is likely. That means they are often denied access to basic, cost-effective care until they reach a medical crisis that triggers far more expensive interventions. By the time they arrive in the ER or require inpatient care, the cost to the system has multiplied. Prolonged hospital stays, ICU admissions, complex surgeries, and delayed recoveries aren't just tragic, they're expensive and avoidable. Our current policy forces Medicaid to intervene only when conditions escalate, resulting in preventable, high-cost care that could have been avoided with earlier access. SB 234 offers a fiscally responsible alternative. It allows for early outpatient-based care that reduces unnecessary hospitalizations, improves outcomes, and lowers overall costs to the state. When we treat kids early, we avoid the downstream expenses of unmanaged disease and crisis-based care. SB 234 doesn't expand Medicaid benefits. It simply establishes a smarter, more efficient reimbursement pathway for care that's already being delivered, just far too late and at a much higher cost. This bill is not just compassionate, it's economically sound. I respectfully urge your support. Thank you.
Thank you so much. AVH, we will go to the phone lines now. If there's anyone who'd like to testify in support of Senate Bill 234, please begin. AVH?
If you'd like to testify in support on SB 234, please press *9 on your phone to take your place in the queue.
Good afternoon, Chair and members of the committee. For the record, my name is Tara Webster, Tarawebster. I'm the policy manager with the Progressive Leadership Alliance of Nevada, calling in support of Senate Bill 234. Plan believes that all people, regardless of insurance or immigration status, deserve access to health care. Ensuring that everyone has access to emergency health care is critical for increasing health outcomes, decreasing financial burdens, and preventing unnecessary deaths for people who are facing serious medical emergencies. We urge your support to implement Ruby's Law, AB 234.
Thank you so much. Next caller.
Hello, this is Caroline Mello Robertson, CarolineMelloroberson. I am a lobbyist for Planned Parenthood Votes Nevada, proud to speak in support of SB 234, and thanks to everyone for their stories.
Thank you, Ms. Robinson. One more caller, AVH.
Chair and members of the committee, my name is Adam Zarin, that's ADAMZARRIN. On behalf of Leukemia and Lymphoma Society, we are in support of SB 234. As the senator pointed out earlier, blood cancer is one of the most expensive cancers to treat, and cost alone is a key barrier to treatment. 4 in 10 cancer patients will choose to skip or delay treatment because of cost, and others will take on medical debt. Non-citizens face unique and often insurmountable barriers to accessing health coverage and consequently health care in the United States. Without some kind of coverage, patients can be denied desperately needed treatment. While emergency Medicaid does have limitations, it is better to have it available than not. For example, one of our pediatric patients, a 5-year-old, was diagnosed with acute lymphoblastic leukemia, ALL, after immigrating to the U.S. His family has an unresolved immigration status. Following the diagnosis of ALL, the patient was admitted to a hospital and received the first cycle of treatment. He achieved remission after 30 days. However, due to his residency status and the subsequent inability to qualify for health insurance, the patient was discharged home with no follow-up care. Within months, he relapsed and was readmitted to the same hospital 2 more times. After his third relapse, 3 months and 20 interactions with the hospital, he finally was placed in a clinical trial at NIH, but this is an unacceptable sequence of events for any family. SB 234 can address situations like this and connect patients to the care that they need. So please consider supporting this bill. Thank you.
Thank you so much for the call. We'll come right back here to Carson City. Please go ahead when you're ready.
Good afternoon, Vice Chair Taylor and members of the committee. My name is Damon Schilling, SCHILLING, and I am the Director of Government Relations for Intermountain Health here in Nevada. We're here in strong support of SB 234. At Intermountain, we believe every person deserves access to emergency care regardless of their immigration status. This bill ensures that some of our most vulnerable neighbors can get the care that they need when they need it the most. Expanding Medicaid coverage for emergency services is not only the right thing to do, it also helps reduce the strain on our healthcare system by supporting timely and appropriate care. We thank Senator Donate, Flores, and Orenshaw for bringing this bill forward and urge you to support it. Thank you.
Thank you so much. Please go ahead.
Hello, my name is Amber Williams, AMBERWILLIAMS. I'm a patient advocate. A 10-year-old boy came to us after a year of escalating symptoms. Initially, when his family sought care for swelling and pain in the eye, they were given only one option, to surgically remove it, without scans, without a diagnosis, and without further guidance. At the time, they didn't know it was cancer, and they had no access to follow-up care because of their child's undocumented status. A year later, when the child returned to the hospital with worsening symptoms, a growing mass, persistent fever and infection, it was finally confirmed he had cancer, but by then the disease had advanced to stage 3. That year-long delay meant more extensive treatment was required, multiple surgeries, extended chemotherapy, and 5 weeks of radiation. Because the child was ineligible for Medicaid, his care became fragmented, reactive, and significantly more expensive. Without coverage, treatment was delayed until the disease progressed, requiring more aggressive interventions and higher cost services. Instead of receiving coordinated care early in the single location, the child's family had to navigate between 4 different hospitals and clinics, many out of state. This approach created cascading costs for the healthcare system. Travel, out-of-state care, and uncoordinated treatment episodes led to greater reliance on emergency Medicaid, which only kicks in when a child is critically ill. That's when care is most intensive and the most expensive. Had Medicaid coverage been available at the time of diagnosis, the system could have avoided repeat hospitalizations, costly transfers, prolonged treatment, and the use of limited charitable resources. Early intervention is not only clinically better, it is financially smarter. SB 234 creates the mechanism to make that shift. It allows Medicaid to pay for care when it is most cost effective, before a child's condition escalates into a financial emergency. This bill isn't about spending more, it's about spending smarter and reducing the long-term financial burden on the state's healthcare system. Thank you.
Thank you, Ms. Williams. Please go ahead, and then we'll go to Las Vegas. If there's anyone else in Las Vegas who would like to testify in support, please come forward at this time.
Hello, my name is Carissa Pierce, Carissa Pearce, and I'm representing Children's Advocacy Alliance. We are in very strong support of this bill, and I will just ditto to the testimony we've heard. Thank you.
Thank you, Ms. Pierce. We'll go to Las Vegas. Please go right ahead when you're ready. State your name for the record.
Vice Chair, members of the committee, Samantha Barnes on behalf of Comprehensive Cancer Centers of Nevada, the largest independent community-based cancer treatment provider in Southern Nevada. We wanted to thank Senator Doñate for bringing this important piece of legislation forward and here today in full support. Thank you.
Thank you so much. AVH, is there anyone on the phone line?
If you'd like to testify in support, please press star 9 on your phone to take your place in the queue.
Good afternoon, Chair and members of the committee. Leanne McAllister, McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. In addition to all of the return on the investment of preventative and early treatment that you've heard from people, I want to also stress how important this is for the retention and the recruitment of pediatricians. The moral injury that I hear from pediatricians throughout our state when they can't provide this type of level of care to all children in the state because of financing issues does a real disservice to their ability to be able to function for all children in the state. And unfortunately, I have seen a number leave the state because of it. I urge you to consider that as well when you are considering SB 234.
Thank you, Ms. McAllister. Next caller.
Hello, my name is Sophia Renteria, SOPHIA I'm speaking as a patient advocate today, and I want to talk to you about money, specifically what it costs when we delay care for undocumented children. Let me share the story of a 16-year-old boy. Because he was undocumented, his family delayed seeking medical attention when he started experiencing night sweats, fatigue, and significant weight loss. By the time he entered the healthcare system, his condition had worsened and the financial costs had already skyrocketed. Without access to primary care, early intervention wasn't possible. Instead, it took multiple surgeries, imaging, bone marrow biopsies, and other urgent procedures, all largely billed under emergency Medicaid. These are some of the most expensive services in our system, and they could have been avoided or minimized with timely outpatient care. Once diagnosed, he began chemotherapy provided through the Charity Care program at Cure for the Kids. But after months of costly treatment, his cancer didn't respond, and he required radiation therapy that isn't available in state. Emergency Medicaid didn't cover it, and our program couldn't either. That meant the family had to seek out-of-state care, adding even more financial strain through travel expenses, time off work, childcare for siblings, and housing near the treatment center. This is the cost of delayed care. It's not just measured in dollars, it's compounded across emergency services, specialized treatment, and avoidable hospitalizations. SB 234 gives us the opportunity to reduce these financial burdens by allowing earlier intervention. And that makes economic sense for our families, for our providers, and for our state. Thank you for your time.
Thank you so much for your call. We have one more caller. No, that was 3 callers in line. We have 1 minute left. And so we'll go whoever was here first, or a good diddle will help spread the love a little bit. Go ahead.
Good afternoon, Vice Chair and Committee. My name is Sabrina Schnur, SABRINA-SCHNUR. I am here today on behalf of Nevada Primary Care Association, the state's FQHCs. Thank you.
Thank you so much. Please go ahead.
Tony Ramirez, TONY-RAMIRZ. Privilege members. Sorry about that. Tony Ramirez with Make the Road Nevada, TONY-RAMIRZ. I have the privilege of representing Katia, who you all heard from, and on behalf of her and many of our members who share a similar story, we are in support. Thank you.
Thank you, Ms. Ramirez. Go ahead, real quick.
Patrick Kelly, Nevada Hospital Association, ditto.
Thank you so much. Our microphones are going in and out again, so we'll see. Please, oh yeah, opposition. I forgot about that. Opposition testimony. Our mics are going in and out, and I'm trying to make sure we get through. Anyone who would like to testify in opposition to Senate Bill 234, please come forward. Or if you're in Las Vegas and would like to testify in opposition, please come forward. Again, we'll have 15 minutes. Hopefully the mics will cooperate. We'll start right here in Carson City. Please go ahead when you're ready.
Good afternoon, Madam Chair and Committee. My name is okay. Lynn Chapman keeps going. Lynn Chapman, and
I'm sorry. Okay, we're gonna pause right. We're just gonna pause right here, and we'll start testimony again once we figure out what's going on with the microphones. We lost. Okay, so we're gonna have until we find out what's going on with our microphones, and when we come back, we will finish the hearing. We will hear from opposition, and we will hear from neutral. I promise. We just have to make sure we can hear it. So we're going to brief recess until we can see what the next steps will be. All right, everybody, we are back in session. We are going to open it up. Try this again. Open it up for opposition testimony. We'll have 15 minutes of opposition testimony to Senate Bill 234. We have 3 here in Carson City, and then we will go to Las Vegas if there's anyone there. And then we'll go to the phone lines again. It'll be 15 minutes, and no one has more than 2 minutes apiece. Please go ahead when you're ready.
Thank you. Lynn Chapman, LYNNCHAPMAN, and I'm the State Vice President of Nevada Families for Freedom. According to KFF, an independent source for health policy research, polling, and news as of November 2024, had this information. Insurance coverage in Nevada. The employers cover 46.7%, Medicare 14.8%, Medicaid 20.6%, non-group 5.5%, military 1.6%, and uninsured 10.7%. Medical debt in Nevada was $220 billion owed in 2021. About 170,000 or 7.2% of adults in Nevada report having medical debt in a given year from 2019 to 2021. Total Nevada Medicaid spending in fiscal year 2022 was $5.6 billion. How many citizens, seniors, and veterans in Nevada need medical help or help in paying their medical debt? We should be looking after them. The people here illegally received help in programs such as WIC, emergency medical help, primary and preventative health care at FQHC, which is federally qualified health centers, free breakfast and lunch shelters, soup kitchens, and emergency situations. Also, you have to figure in housing, education, jobs, and legal services. Who pays for all these free services? We, the taxpayers, who are the ones who have to shoulder the burdens of everybody else. We already have done our part in helping others. Federal money, state money, it all comes from the taxpayers. Vote no on SB 234. We simply cannot afford it. Thank you.
Thank you, Ms. Chapman. Please go ahead, sir, when you're ready.
Thank you. Good afternoon, Vice Chair and Committee. My name is Joshua Skaggs, and I'm the Legislative Affairs Director for the Nevada Republican Party, here in opposition to SB 234. Our platform states we support legal immigration from all nations, creeds, and races who assimilate, embrace the Constitution of the United States. Our platform further states we support securing the United States borders and effective enforcement of immigration laws. Allowing undocumented immigrants to access taxpayer-funded benefits, including Medicaid, undermines the principles of legal immigration and the rule of law. By extending Medicaid eligibility to undocumented persons, even if it's only persons under 21, we send a clear message that violating immigration laws will be rewarded rather than penalized. This creates incentives for illegal immigration, further straining our resources and eroding the integrity of our immigration and healthcare systems. SB 234 says that Nevada would seek federal funding to cover the cost, but that's a problem too. Medicaid is a crucial safety net for millions of low-income U.S. citizens, legal residents, and their families. Nevada may face challenges funding this program already due to reliance on temporary federal funding to pay for permanent expansion of the program. During COVID, Nevada agreed to transfer individuals between 100% and 138% of the federal poverty level from the Nevada Health Exchange, where the federal government paid for their health care, to Medicaid, where Nevada would have to pay. However, the federal government agreed to temporarily cover those costs. Now that they are looking to stop covering these costs, Nevada has to decide whether to find a way to pay for expanded Medicaid or change the rules to return these beneficiaries to the health insurance exchange, where subsidies would again be covered by the feds. Permanently expanding Medicaid to undocumented children and paying for it with federal dollars that may not continue could put us in the same situation in the future.
Mr. Skaggs, sir, you're at 2 minutes. Would you wrap up your comments, please?
Yes.
Thank you.
In the same situation in the future if federal funding stops, except that we'd have no way to transfer care for these children to the federal government. Please vote no on SB 234. Thank you.
Thank you so much. Please go ahead.
Thank you, Madam Chair and members of the committee. My name is Janine Hansen. I'm the state chairman of the Independent American Party. In our platform, it states that we oppose all tax-funded benefits for illegal aliens. I am very sensitive to the problem of cancer. My son has been extremely ill since last June. They had no insurance, no Medicaid, and now they have no breadwinner. He has a large family, and we have been fundraising, and family has been helping a lot. They celebrated his daughter's first birthday in March, and they celebrated that he was still alive. We don't know if that's going to be the case. So there is a lot of sympathy, and we understand. Medicaid spending in Nevada in 2022 reached $5.6 billion. Nevada spends $5,267 per year on average on each person enrolled in Medicaid. The average kidney transplant, for instance, costs between $400,000 and $500,000. We understand that this is just the beginning. Every bill in this legislature benefiting illegal aliens is always expanded in subsequent sessions. So this is just another opportunity to expand more services for illegal aliens. In a testimony before the U.S. Senate Committee on the Budget in September of 2023, Robert Rector from the Heritage Foundation said, "The current net fiscal cost of illegal aliens in the United States is between $84 and $94 billion per year. This means that illegal aliens receive $84 to $94 billion more in government benefits and services than they pay in total taxes." We are concerned about our economy. We're concerned about the high taxes in our state. 56% of every dollar that Americans have goes to federal, state, and local taxes, much of it hidden. We can't afford more in Medicaid for illegals. We can't afford more even for American citizens at this point in time. Thank you.
Thank you, Ms. Hanson. We're going to go to Las Vegas. Seeing no one in Las Vegas, AVH, we will go to the phone lines. If there's anyone else here in Carson City, please come forward. We'll go to you next after the phone lines. Go ahead, AVH. Thank you.
If you'd like to testify in opposition, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers in opposition at this time.
Okay, thank you so much. And we'll come right here to Carson City. Opposition testimony. Please go right ahead. State your name for the record, and you'll have 2 minutes.
Tanya Freeman, TANYA, and I am in opposition to this, and I agree with those that came before me.
Thank you so much. Okay, we did opposition. We did support. Any neutral testimony here in Carson City? Any neutral testimony to Senate Bill 234? Come forward. Seeing none, and seeing none in Las Vegas. AVH, is there a neutral testimony on the phone line?
If you'd like to testify in neutral on SB 234, please press star 9 on your phone to take your place in the queue.
Yes. Can you hear me?
Yes, go ahead.
Okay. I just tried to press star 9 for the opposition, and it didn't work, and it went to the other caller and then straight into neutral.
No,
So
that's
I
no
just
problem.
want
We'll accept the opposition testimony. Please go ahead.
Yes, I just want to oppose this bill. It's no good. It's not fair. I don't know if you guys know that these people use our ambulance services as taxi rides. And this is
Ma'am, I'm going to
coming
interrupt
from
you for just a
all
moment. We
from
need your
my
name for the record. Can we just get your name for the record? Then you can go right back to your opposition.
Yeah, Lee. Yeah, Lee.
Okay, last name, please, or first name?
It's Beeniger.
And if you wouldn't mind spelling that, you'll get all your time back. We just want to get the record straight.
Deniger.
Okay, ma'am. Thank you. Go right ahead. Thank you so much.
Yes, I'm in opposition of this because I don't think it's fair or right, and it's not even moral for these illegals to be using our taxpayer money to be getting free health care. Coming from my neighbors, and there's at least a couple 100,000 on my side of town. This is coming from them. They tell me they use it if their grandpa gets a stomach ache or one of their kids isn't feeling good. It's a free trip to the emergency room. You're seen first, and you're in and out of there. And I don't believe it's right. It's not fair. It's not moral. And I don't think the taxpayers ought to be paying for this. So I want to oppose this bill. And if you guys take that into consideration, everything that I said, I would greatly appreciate it. What's right is right, and we all know this is wrong.
Thank you so much. AVH, do we have another caller?
Yes, Chair, one moment, please.
Greetings. Hello there, everyone. CYRUS, HOJJATY. I stand in opposition, if that is okay, if I can go on with my testimony. I appreciate the help that is given for vulnerable people, and I've heard good arguments that it may even reduce costs. However, my concern is this will create the incentive for more people to come into our country unlawfully. And, hey, if you want to subsidize their health care, at least make the casinos pay for it. They have the lowest gaming taxes in the United States. And let me make this very clear. My main concern is the dirty politics behind all this, not the immigrants themselves. And by the way, I was an unauthorized immigrant. No, I'm just kidding. April Fool's joke. Anyway, thank you so much. Please oppose this bill.
Thank you so much. AVH, do we have another caller?
Yes, Chair.
Is anyone else in Carson City, please come forward at this time.
Yeah, hi. Are you still accepting opposition testimony?
Yes, we will. We seem like we missed a couple, so we'll go ahead and take
great.
this. Go ahead.
Oh, okay, super. Good afternoon, Vice Chair, members of the committee. Bob Russo for the record. I am in opposition to Senate Bill 234. Many Nevadans are struggling to make ends meet. The expansion of Medicaid to those illegally in Nevada will place a greater tax and financial burden on struggling families and individuals. And given that the expansion of Medicaid will likely exceed monetary resources, we could see a push to raise taxes in the future. Plus, this bill will stretch our medical resources thin and away from many legal Nevada residents that need them. We must ask ourselves sincerely if we want to follow California's lead and drive Nevada into financial ruin with bills such as SB 234. California has become financially unsustainable. As of the beginning of 2024, it was $76 billion in debt. They have spent almost $11 billion on indigent aid, mostly to people who are in the state illegally. And Gavin Newsom wants to borrow $3.4 billion from the general fund to pay for health care for people who are primarily in California illegally. The program in California is a financial downward spiral. The middle class is leaving in droves because they are paying the highest taxes in the nation. And what are they getting in return for it? More crime, high electric bills, poor social services, inferior roads and infrastructure, and below par schools. Once the darling of the nation, California has fallen into a state of disrepair. It's a perfect example of how socialist policies lead to ruin. Again, is this the direction we want to see Nevada heading? Common sense says no, but this is exactly where Nevada is heading if we approve bills such as Senate Bill 234. So please vote no on this bill to keep Nevada financially sound, and so our resources can be directed to legal residents of Nevada who need them. Thank you very much.
Thank you for the call. We have time for one more caller, AVH.
If you'd like to testify in neutral on SB 234, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers in neutral at this time.
Okay, thank you so much, and thank you for everyone who testified. Senator, would you like to have closing comments?
Thanks so much. Thank you so much, Vice Chair Fabian Oñate, for the record. I want to dispel some misinformation that was spread throughout this testimony, so I just want to refute some of the claims that have been made. First and foremost, I want to start by thanking Ruby and Katia for sharing their stories. I think it's always important to highlight at least their scenarios. And what makes it so interesting is in Ruby's scenario, she is now a U.S. citizen that has to suffer as a U.S. citizen from the gravity of the resources that she was not offered when she was undocumented. Again, she is a Nevada resident. she is a taxpayer, and she has to deal with the ramifications because she was denied the coverage eligibility that SB 234 would have prevented. In the case of Katya, right, she was here legally. She's a DACA recipient. That is considered lawfully present. And so she was denied care as a 16-year-old for her cancer treatment. These are cases where individuals are here lawfully present, but yet they are still denied access to treatment for their particular diagnosis. And so I question this consideration that they are not taxpayers of the state. Are DACA recipients not taxpayers of the state? When they go and purchase food, not food from the grocery store, but when they go and they purchase items from the grocery store and they pay sales tax, is that not a version of being a taxpayer of the state? When they file taxes from the job that they work for here in the state, again, they are DACA recipients. Are they not considered taxpayers of this state? And so if the question is that we all agree that individuals who are here lawfully present should have access to the critical services, then I would expect my committee members to agree to commit to expanding Medicaid to individuals who are here lawfully present, including DACA recipients like Katya. And so I hope that we can all, if that is the agreement that we want to make for this bill, then that is a conversation that I'm willing to have, at least for covering those who are lawfully present, because clearly there are cases, as Katya, as we were able to mention earlier in the presentation. But beyond that, right, regardless if they're here lawfully present or not, we are talking about kids with cancer. Avoid the conversation of the politicalness of the semantics and everything that we put forward, right? These are kids with cancer. They are in a situation where they have been deemed either in a life-threatening case or terminal. Parents in this scenario have to prepare for either readmitting their kids back to the emergency room or preparing for their funeral. That is the situation that we're talking about today. Regardless of the services that are already being offered, the taxpayers ultimately still have to pay for it when they come into the emergency room. All we're asking is for the continuation so that it's improving the quality of care for the patients that need it most and fundamentally providing a pathway for them to live. That's all we're asking, so that they can become the next Ruby. And if they're afforded the opportunity to become U.S. citizens or to be here lawfully present over the period of time, we can at least alleviate the concerns for when they get that moment. And that's what this bill does. And so I thank the Vice Chair for allowing me the chance to present this bill.
Thank you, Chair Danyante, and those who presented with you. We will now close the hearing on Senate Bill 234. And as the chair retakes his position, we'll be prepared to move forward.
Thank you so much, Vice Chair. Let's go ahead and move on to Senate Bill 187. This is our second bill on the agenda, and so this bill revises provisions relating to child welfare. And I will welcome Senator Pazina and Senator Nguyen to please begin when you're ready.
Thank you so much, Chair Danyate, Vice Chair Taylor, and members of the Committee on Education, of Health and Human Services. Listen to me. I looked at so many of you from Education, I got tripped up. For the record, my name is Julie Pazina, and I represent Clark County in Senate District 12, and I'm fortunate to be sitting next to my colleague today from Senate District 3, Rochelle Nguyen. It's my pleasure to present along with her Senate Bill 187 to you today, which relates to child welfare. I'd like to point out, if everyone's had a chance to look at the amendment on Nellis, that would be very important, because the amendment deletes sections 1 plus sections 3 through 18. So if you have not seen the amendment, there are a lot of changes. And in section 2, 3A, it changes obtain to initiate. So I would just say, if you haven't looked at the amendment, please look at the amendment, because section 2 is what is remaining. For a bit of background, currently there's no shared definition of the phrase best interest of the child across states. In some states, it can be defined based on safety and well-being of the child, on access to care, and adequate resources. In other states, the determination is left to the discretion of the courts. In Nevada, the court determines the best interests of the child with guidance and insight from investigations conducted by the Division of Child and Family Services of the Department of Health and Human Services. Senate Bill 187 proposes that child welfare agencies make decisions regarding medical or mental health care treatment for the children in their custody in a prompt manner. To briefly walk you through what is now a very short bill, Section 2 provides that agencies providing child welfare services either grant or deny consent for medical or mental health treatment of a child in their custody within 14 days of the request. Additionally, Section 2 requires the agency to make reasonable efforts to initiate such consent and promptly provide notice of the consent of order or the denial of the consent or order. And some of you may remember that this was on the agenda, I think about a month ago now, and we wanted to meet with stakeholders for a considerable time, have a lot more conversations to really determine how best to move forward with this bill. And based on those conversations with many, many stakeholders, this is where we are. So I apologize for the delay in hearing this bill. We thank you so much for hearing it today. And I'm joined by Senator Wynn, who is going to help answer questions and share anything she'd like to as well.
Thank you. My name is Rochelle Wynn. I proudly represent Senate District 3, and I'm very excited to be here with Senator Pezzina presenting our first bill together. I have a little bit of experience, and I think we have a shared experience, and the reason for the basis for this bill came out of some of those shared stories that we heard from people in the community that were either fostering children or were in a foster to adopt situation, and they were really having a difficult time getting approval and permission from child welfare agencies for some of these children to make sure that they could start and get them the medical and mental health treatment that they needed for the children that were in their custody. So a lot of times people are like, why are you bringing this bill? What exactly does it do? I think Senator Pezzina described it perfectly. It puts some of those guardrails in there. It gives some protections to the children so they aren't languishing to get that needed medical and mental health treatment that they might need, especially these kids that are more vulnerable and are prone to need some of these care. This puts it in a situation where we are addressing those things quicker.
And Julie Pezzina, again, for the record, I would just add that we have so much respect for the caseworkers and those that are in the front lines every day trying to do the very best to make sure that the best interests of the children are met. And we've also been in touch with Clark County and are working with them. We received an amendment around, it was pretty late yesterday evening, so we're still in discussions about that. But for now, we've been working with every stakeholder to try to ensure that we can meet some of the needs that were discussed with us by some of our constituents over the interim. And with that, we're ready for questions.
Thank you so much. Committee members, any questions? Senator Titus.
Thank you. And again, I think what the reality is, just looking at that we've had time to digest it, you've gutted your bill and you put it in one section. And just to be clear, the attorney at the table, please, when you say reasonable efforts to initiate, what's considered a reasonable effort? Is there a timetable on that? And you make a phone call?
We did. Oh, I'm sorry. What? Oh, Rochelle Wynn for the record. Probably committee counsel would probably be best to describe what that meant. Obviously, reasonable efforts. We also put in the 14-day time effort, and that's also included in that. I think there are some standard practices and procedures that are already taking place in there on how they would initiate those efforts. But I would leave that to committee counsel to maybe describe whether or not there needs to be more specificity. And that might be something that we can look at in modifying some of this as well.
Thank you. Mr. Robbins is online if you want to answer that.
Eric Robbins, LCV Legal for the record. I not being someone who regularly practices in the child welfare area, that's going to require some additional research to answer.
Because I guess for me, I want to. This is a statewide bill. Counties have different resources, and so whatever that reasonable effort is, based on where you're located, or just based on statute, or based on standards. That's I guess what my question is, and it doesn't change the tenor of the bill for me.
Rochelle Wynn for the record. Go ahead.
I was just going to say, as far as like based on location and resources available, like the reasonability is a standard that's fairly common in the law, and that is going to take all of that stuff into account. So when a court is examining what reasonable efforts are going to be, they will look at the resources available and the particular circumstances.
Okay, thank you. Thank you. That's actually the only question I had on the bill. Thank you.
Rochelle Wynn for the record. I was going to say that I know we use like a reasonable person standard throughout like the statute, and most of the time that comes into play when you're litigating things and determining whether or not a county or an agency act reasonably, and I think that would be up to like a finder of fact in that kind of situation to determine whether or not those efforts, based on the resources, based on where the community is, based on what the circumstances were, in this case, like of a health need, if that was reasonable or not.
Sorry, I'm just double checking something. Any other questions? Let's go ahead and open it up for testimony. If you are in support of the bill, we ask for folks to please come forward. And again, it's the 15-15-15 breakdown, and you may begin.
Okay. My name is Maximilian Lowe. I'm in support of.
Hold on 1 second.
Okay,
I think we're having issues with.
Oh no.
Let's take a 5-minute recess, please.
This happened in the assembly a couple weeks ago.
My name is Aisha Goins, AESA.
Testing, testing.
I know, right?
All right, we're gonna try one more time.
It says clear.
All right, we just got cleared. So I will start I don't believe we started testimony and support yet, so we're gonna start all over. I will put 15 minutes on the clock, and you may begin.
My name's Maximilian Lowe, LOWE. Here strongly support SB 187. This bill encourages timely medical care for children in protective custody, prioritizing placement with placing them with relatives when possible, and keep siblings together when it is in their best interest. Delay in medical treatment for children in protective custody harms them, and how family connections provide stability when in times of crisis. By requiring agencies to act within a 14 days for medical consent and expediting relative placements, SB 187 will improve outcomes for Nevada's most vulnerable children. This bill is necessary steps towards a more responsible child welfare system. I urge you to support SB 187. Thank you.
My name is Carissa Pierce, Carissa Pearce, and I am the Government Affairs Manager with Children's Advocacy Alliance. We were part of the group that helped or worked with the sponsor on amendments to the bill and bringing up some of the concerns for how it was initially drafted. So I want to say a huge thank you to the sponsors for giving us that opportunity to provide feedback, and to express our support for this bill as it has been amended. Thank you.
My name is Aisha Goins, AESHAGOINS. I'm here on behalf of SCIU 1107, and we just want to thank the sponsors for working really hard on getting this language in a space where we can support. It was a lot of work, and and being a part of a group and them listening really does matter, and it does make a difference. I think that's how we get good policy, so SCIU is in support of this bill.
Thank you so much. Anyone here else here in Carson City? Seeing none here in Las Vegas, AVH. Is there anyone online?
To testify in support on SB 187, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move on to opposition testimony. If you are opposed to SB 187, please come forward. Seeing none here or in Las Vegas, AVH. Is there anyone online?
To testify in opposition, please press star 9 on your phone to take your place in the queue. There are no callers in opposition at this time.
Thank you so much. And last but not least, anyone in neutral on this bill, please come forward. And you may begin.
Good evening, Senator Gignate, members of the Health and Human Services Committee, Joanna Jacob, JACOB, on behalf of Clark County. And I will just say I'm working with my colleague, Cadence Matievich, Matijev. I lost Matijevich on behalf of Washoe County. I lost train of my thoughts because I am very tired. I apologize for sending an amendment to Senator Pezzina and Senator Wynn very late last night. We have been working diligently, as they noted in their testimony, on trying to work on this bill and also try to improve some of the communication between our foster families and our child welfare agencies. We are almost there. I think that one of the most important things, as stated, we are neutral on the bill and we're working on the amendment because one of the most important issues, as relayed to me from Senator Pezzina and the people who are behind this bill, is on access to medical care. And there's certainly a variety of reasons why we would have to try and obtain consent from biological parents or other people that can cause delays, and we're trying to make sure that we can put some guardrails, as noted, about the timing of that and the communication from the agency back to our foster families who are caring for the kids. So we are almost there, and we hope to bring back an amendment that you could process for a work session on this. And want to thank Senator Pezzina, Senator Wynn, and everybody for working on this bill. So thank you very much.
Thank you so much. Anyone else in neutral? Seeing none here or in Las Vegas AVH, is there anyone online?
To testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. Given the time considerations, I'm going to go ahead and close the hearing on this bill and move on to our next one. And so I would go ahead and ask the presenters of SB 390 to please come forward. And I'll go ahead and open this bill hearing. This bill revises provisions relating to the support of children. And so I believe our presenter is here. So please begin when you're ready.
Good afternoon, Chair. Thank you for the opportunity to present this bill. My name is Aisha Goins, and Senator Neal also will be joining us via telephone. It's my pleasure to present Nevada Senate Bill 390. I just want to just kind of give some background on this bill, and then I will present the structure of the bill. And I had a presenter with me in Las Vegas, but he had to leave, so it will just be me. All right? Thank you very much. Federal law requires states to establish procedures to suspend driver's license, professional license, and recreational license of individuals who fail to comply with child support-related subpoenas and warrants, are in arrears on child support payments, and the current Nevada law mandates district attorney public agencies to report non-compliant parents to DMVs. The result has been automatic suspensions of driver's license and motorcycle licenses. The key problem with the current system is the licenses lead to suspension, loss of transportation, job loss, reduced income, further inability to pay child support. This disproportionately impacts low-income communities. 40% of all license suspensions nationwide are for failure to pay fines or appear in court. It creates a two-tiered system where the wealthy pays fines while the poor lose licenses. I'm sure that that's just a conversation. An economic waste, and then also it harms families. 76% of people with suspended licenses continue to drive, leads to criminal charges, fines, further incarceration, and then what happens is children lose both financial support and parental presence. So the key changes in this bill is the driver's license suspension provisions, which is outlined in Section 1. It makes reporting to the DMV optional rather than mandatory. It prohibits licenses suspensions when it would be an impediment to employment. It redefines arrears for the DMV reporting purposes. A person must be delinquent for at least 6 months versus 2 months currently. In Section 4, it maintains existence requirements for hunting, fishing licenses suspensions. In Section 2, it requires administrators to ensure Nevada program complies with federal requirements. It also preserves eligibility for federal funds while implementing more compassionate enforcement. The compliance mechanisms, there's a notification requirement, first-class mail notification to all non-compliant parents, a 30-day window to comply before enforcement action. There's a hearing process where parents may request hearing within 30 days, good faith meeting required before a hearing, and masters make recommendations on enforcing actions. Options for compliance is pay full amount owed, pay past due 12 months of determined arrears, enter approved payment plans, and provide proof of medical insurance coverage if that was the court issue. Chair, I want to acknowledge that I had a conversation with Senator, and she is going to be submitting another amendment where partial payment would be considered, and that would be after, but I did want to say that that is a consideration. The anticipated benefits of this bill is maintain child's interest. Parents can keep employment to support children. Reduces administrative costs of suspension and programs. 86% of Americans drive to work. Public transportation is limited in many areas. In rural areas, walking and biking also is a hard alternative. This will include and create better transportation equity, and it will create better employment protection. Many jobs require a valid driver's license, and better employment means more and consistent child support payments. Chair, that is the presentation and the changes that are being requested in this bill, and I and Senator Neal are available for questions.
Thank you so much. Committee members, do we have any questions? Senator Stone.
Thank you, Mr. Chairman, and thank you for your presentation. Just a couple of questions. You're making the arrears before any mitigation can happen from 2 months to 6 months. Number one, how is that acceptable? I mean, for somebody that's ordered to pay male or female, husband, wife, boyfriend, girlfriend, whatever, they're ordered by the courts to make child support payments, and now we're going to allow them to be 6 months in the arrears before we can do anything, number one. Number two, is the driver's license not the hammer that's going to make sure that whoever is obligated to pay those child support payments does in fact do that, or there's something significant that they're going to lose, and maybe you have to use public transportation to go to your work. And so if you can answer those two questions, I'd appreciate it.
Thank you for the question, Senator. The research has proven that having suspended licenses or what they consider debt.
This is Senate. Let me answer this, Ms. Goins, please.
Yes, Senator, please.
Thanks. So this is Senator Dina Neal for the record. So I had this bill in 2017, and now I'm trying this bill again. So just for the record, there are 7 states that actually have a 6-month provision. They have had it for a long time. They have not been audited by the federal government. The idea was to try to give some flexibility to what the current statute is. The current statute actually kicks in around $1,000, which, depending on what your payment is, that could be 2 months, that could be 1 month. And so driver's license are one of the highest privileges that you can actually have. And so what I'm trying to do is give some flexibility for, number one, citizens who are where there's a collateral consequence associated with losing their driver's license. As Ms. Goins stated, they're still driving illegally. There are other, I would say, effects of this. The American Bar Association actually did a report on this 15 years ago, which is when I cited in my 2017 hearing, which didn't even have the same provisions. And then also the ACLU, National ACLU, cited to the impacts of when you lose your driver's license. So I chose the 6-month provision after talking to the Division of Welfare Services, trying to understand what would be the impact of 6 months. Then I got the data that there were 7 states that had the 6-month provision. There's 16 states that have the 3 months provision, but there are at least, that's 20 plus other states that have a much longer time period before they actually do the driver's license suspension and revocation.
Thank you, Senator Neal. It's nice to hear your voice, and we look forward to your return.
Any other questions? Seeing none, I have technical questions, but I think I'll do them offline. So thank you so much. And Senator Neal, it's always a pleasure to hear your voice. Let's go ahead and open it up for support testimony. If you are in support of this bill, please come forward. Again, 15-15-15 rule applies. Please begin.
I'm Max Lowe. I'm here to support SB 390. This bill strengthens Nevada's child support enforcement system by ensuring parents fulfill their financial obligations to their children. By clarifying arrears definitions and streamlining notification procedures, SB 390 holds non-compliant parents accountable while ensuring timely support for children who depend on it. This bill is a necessary steps to protect children's well-being and ensure they receive the resources they deserve. I urge you to support SB 390. Thank you.
Thank you so much. Anyone else here in Carson City? Anyone in Las Vegas? AVH, is there anyone online?
If you'd like to testify in support on SB 390, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 035, you are unmuted and you may begin.
Thank you so much, Chair and members of the committee. For the record, my name is Quentin Savoy. That's Quentin. Last name Savoy, S like Sam, A like Apple, V like Victor, WOIR. I'm the president of the Las Vegas branch of the NAACP. We appreciate the presentation that Ms. Goins provided, and we are in support of SB 390. Thank you.
Chair, there are no more callers in support at this time.
Thank you so much. Let's move on to opposition testimony. If you are opposed, please come forward. And we'll start here in Carson.
Thank you, Chair Doñate, members of the Senate Health and Human Services Committee. My name is John Jones, here on behalf of the Nevada District Attorneys Association. And this is my first time in this committee today. So for those of you who do not know, the Nevada District Attorneys Association is comprised of the 17 elected district attorneys in the state of Nevada. And one of our core functions is to administer the child support program in the counties, at least a portion of it. And I can tell you that ensuring that the children of our state receive the support of both of their parents helps increase the health and educational outcomes of those children. Further, it reduces a child's reliance on state assistance to meet those same goals. It reduces reliance on state assistance. Thus, we consider the child support program a twofer. It helps ensure healthy children, and it helps reduce costs to the state. It's a federally mandated program, and it's incentive-based. The more successful we are at collecting money from parents who are not paying, the more incentive funds we receive back from the federal government. So it helps us run our program at little to no cost to the state. I want to be clear that we do not automatically suspend driver's licenses. There is a process that we must go through, and we do not suspend licenses simply based on somebody's inability to pay. When we get to the level of license suspension, it's because somebody has failed to meet their obligation to their child or children and failed to interact with the child support system. They've essentially blown us off. These are not people, quite frankly, who deserve the privilege of a driver's license. It is an essential tool in our arsenal to make sure parents are meeting their obligation to their children, their court-ordered obligation to their children. There are 54 federally monitored child support programs. A little over 10 years ago, Nevada was 54th in terms of collections, 54th. We're now 12th. We're looking to get into the top 10 of states that are collecting money for children. This bill will hinder our ability to get in the top 10. We urge this committee to reject the attempts to strip the enforcement program of an important tool and risk our rise into the top 10. And Chair Doñate, with your permission, I do have two people present with me. One is Karen Cliff, who is the Assistant District Attorney over Child Support in the Clark County DA's office. She's down south. And I have Marco Markovic, the Program Manager for Washoe County DA's Child Family Support Division as well.
Thank you. We do have a quick question for you all specifically on the semantics. So,
And I am happy we are available for questions. I want to encourage them.
okay. Vice Chair Taylor, please.
Thank you, Chair. And thank you for being here, and thank you for the presentation, who made the presentation. I have a question. Now, this bill, it doesn't prevent you from suspending the license, right? It delays it. Help me.
John Jones on behalf of the Nevada District Attorneys Association, and I think Marco or Karen might be better to answer this question.
Okay.
But it seems like that it does just extend it to 6 months. But there's 2 points that I want to make. One, the standard in the statute is basically illusory. You can make an argument that a suspended license will hinder your ability to find work. You can always make that argument. And this statute says that if you make that argument, essentially, the court doesn't have to suspend your license. It's essentially neutering one of the most important and effective enforcement tools that we have. And I don't know if one of my 2 co-presenters can better answer that question.
Karen Cliff on behalf of the Family Support Division for the Clark County District Attorney's Office. John Jones is exactly right. It's the vague and sort of overly broad verbiage that suspension will cease if the payer's present or future employment would be impacted. That's not currently written in the existing NRS, which right now the safeguards and the process are written in NRS 425.510.
Go for it.
Thank you very much. Quick follow-up. You probably have data on this, and congratulations on moving up, right, and collecting the money for kids. I think that's really important. Do you have any data that talks about how it impacts Black, brown, and poor communities, in particular communities of color? My suspicion is that those communities are impacted disproportionately, and I think that's where Senator Neal's coming from.
Karen Cliff on behalf of the Clark County District Attorney's Office. I would say that revisions to the existing statute will impact greatly those communities that you just mentioned. Reason being that, you know, we enforce 49,000 cases just here in Clark County alone. Many are from the communities you just mentioned. Changes to this bill will absolutely reduce the collections for those families and require them to seek welfare assistance. Moreover, when we're unable to involve ourselves in their lives for 6 months, that's an increase in their arrears, right? So that's gonna affect those payers. When we can't engage with them for 6 months, that additional 4-month delay means their arrears increase. That affects credit reporting, that affects passports, that affects a host of issues. So it hinders their life as well.
Okay, I appreciate that, but how about data on how about my question? Does it disproportionately impact communities of color? That's what I mean. I'm looking at some background information that I have, and it seems like it's been like over for the state. Close to 30,000 licenses have been suspended. I think almost 22,000 in Carson City, in Clark County. So I'm just trying to say, how do we? I mean, certainly we want children to get the money, no question at all, absolutely. But I'm trying to see the results of what it is, and just how the impact could be. Does that make sense? Ms. Click, thank you for your answer. I appreciate it, but I want to hone in on this one.
Okay, well, and just to add, the statute provides for a restricted license to get individuals to and from work. So there should be no reason that should impede anyone of any color.
Okay, how about the data? I'm sorry, yet I'm no attorney, but I haven't gotten an answer. And I want to keep. It's late. Everybody need to go home. But I just want to know what
I don't
are you
have
doing?
the data.
Okay.
I
No,
don't have the data on any race that's impacted.
No, and that's okay. Is there a way that we can get that?
John Jones on behalf of the Nevada District Attorneys Association. I will reach out to my member agencies to see if we have that data. First of all, if we do, I'll be happy to turn it over to you, Senator.
Okay, I appreciate that. And if I may, if you don't collect that data, I'm going to ask that you begin to, because I think it's important that we look at how the things that we're doing are impacting, because we do want to make. The children need the money. There's no question about that. I'm just trying to see what is the best way to get there, and the impacts of what it is that we're doing. What kind of impact is that having?
John Jones on behalf of the Nevada District Attorneys Association, absolutely. I think that's a great suggestion. But I do want to make the point that as long as somebody is engaging with the child support program, we do not suspend their license. So if you're talking to us, if you're saying, I have an employment issue, we go to the court and we try to figure out what is the best solution for the payor and the child. So we work with them. But the problem is if they don't engage with us, then our only option is to move to some of the enforcement tools that we have in statute, including driver's license suspension. What we want the most is for them to engage and talk with us.
I do have a couple more questions. We'll talk offline. Thank you. I appreciate that, though. I do.
Let's move on to the next testimony. Nope. Nope. Go for it, please.
Thank you, Mr. Chair. I'm Marko Markovic, Washoe County District Attorney's Family Support Division. Family Support Division for the Washoe County District Attorney's Office is strongly opposing this bill. It is critical to remember that child support is used to meet children's basic needs for food, clothing, shelter, education, and healthcare. Failure to pay child support more often than not results in a failure to meet children's basic needs. In addition, it's important to recognize that the primary use of the license suspension process is to provide a parent who is responsible for providing financial support for his or her children with the incentive to pay that support. Each situation is evaluated on a case-by-case basis to determine if the license suspension is an effective tool to use and is it likely to result in a payment of child support. I would also like to take a moment and just briefly provide the overview of how the process works for the clarification. So if you are the payer who is behind 2 months on paying your child support, you will receive the notice from our office, which is called the warning notice, and we will ask you to contact our office within the 30 days to talk to us and explain why you are not making the payments. If you fail to contact our office within the 30 days, we're going to send you the second notice, which is a notice of intent to suspend the license. We give you again 30 days to talk to us, request the hearing, provide explanation, work with us on how you can continue paying this. We are still trying to work with you not to suspend your license. At that point, if you don't respond to us after this additional 30 days, we are sending your name to the DMV. At that time, DMV will issue the notice that they are going to suspend your driver's license and they're going to give you 30 days to work with the district attorney's office to resolve this issue. So theoretically, any payer has a 90 days to work with us before their driver's license is suspended. If we go into 6 months before we start this conversation, we are potentially looking of no payments within 9 months or more.
Thank you so much, sir, for your comment. If you can send it to us in writing, we would greatly appreciate it.
Of course, thank you.
Good evening, Chair Donyate, members of the committee. For the record, my name is Cadence Matijevich, C-A-D-E-N-C-E, M-A-T-I-J-E-V-I-C-H, here on behalf of Washoe County, and this evening also on behalf of my colleague from Clark County, Joanna Jacob, J-A-C-O-B, no S, please. We are also in opposition to this bill for many of the reasons that you've heard, and I think the process and the timelines that you just heard from Mr. Markovich are really important. The current statute, it's at the 60-day mark that we begin that process, and you heard from him that you're getting notices at that 60-day process. They give you time, and the action's not actually taken for several months longer. If we wait for 6 months to start that clock, we potentially have families that aren't receiving support for 9 months to up to a year, and we think that's simply too long. We ask you not to approve this bill. Thank you.
Hello, Chair and Committee. Amy Hines-Sutherland, Health and Human Services Manager for the Nevada Association of Counties. My name's spelled AMYHYNE-SUTHERLAND. Because of the anticipated impacts to child support collections and also then to families, and also to echo the concerns shared by the Nevada District Attorneys Association, our members oppose SB 390. Thank you.
Good evening, Chair Donyate, members of the committee. My name is Taylor Allison, last name A-L-L-I-S-O-N, representing Lyon County, and for the sake of time, we also oppose SB 390 for the reasons presented by Nevada District Attorneys Association and NACO. We do believe that our child support enforcement programs are working, and we appreciate the Senator, bill sponsor, for hearing us and our concerns related to federal incentives and our ability to present child support enforcement programs in the future. Thank you.
Thank you so much. Let's go to Las Vegas, please.
Good evening, Chair Dignate and members of the committee. My name is Karen Cliff. I represent the Family Support Division of the Clark County District Attorney's Office. We stand firmly opposed to SB 390. Our office enforces 49,000 cases. That's Clark County alone, which translates to serving 49,000 families. Currently, our office collects an estimated $9.5 million per month for children and families. The state collects $16.5 million a year from the driver's license suspension notice alone. SB 390 seeks to amend this process, and the two most concerning provisions are: one, extending the delinquency period from 2 months to 6 months, adding an additional 4 months of non-payment before we can utilize this enforcement tool. Two, it includes vague and overly broad verbiage that suspensions to cease if the payer's present or future employment would be impacted. This language weakens the tool, and it has a potential for abuse. The delay initiating suspension from 2 to 6 months and the inability to properly use the tool renders it meaningless. We're unable to collect as we should for families. The timely support's not being met, and overall, it will result in a greater reliance on state welfare. Timely and consistent support is the difference between having enough food, stable housing, and proper medical care. A delay of 4 months may not seem significant, but in the life of a child, every day a family goes without the financial support they need will cause significant harm. Thank you for your time.
Thank you so much. Anyone else in Las Vegas? AVH, is there anyone online?
If you'd like to testify in opposition, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 722, please press star 6 to unmute yourself.
My name is Kimberly Wilson. I represent Nye County Family Support Division, and we strongly oppose SB Bill 390. We agree with everything that Karen Cliff has said, the DA administration has, or association has said, and Mark Markovich has said. Thank you.
There are no more callers in opposition at this time.
Thank you so much. Let's move on to neutral testimony. If you'd like to testify in neutral, please come forward. Seeing none here or in Las Vegas, AVH, is there anyone online?
To testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. I will now allow Senator Neal to do closing remarks. Let's see if it works.
Can you hear me?
Go ahead.
Thank you, Senator Dignate and the chair and the Committee on Health and Human Services for hearing this bill. So I just want to make it super clear. I am not preventing the District Attorney's Office or the Child Support Office from collecting the money. What I am doing is delaying the use of the driver's license suspension tool. That is my intent. In law, there are currently other factors that can be looked at and other tools before they go to the driver's license suspension. They have yet to discuss the other tools that are actually available before you actually use the driver's license suspension. And one thing that's in the process is that in that notice provision, when they talk about that a warning notice is sent, and then if there's no response after 30 days, they then send a notice of intent to suspend. And then if no response is received, the notice is sent to the DMV. And so the collateral consequences of what is happening is that typically, right, there is typically no restricted license that an individual goes to get. They're going to go get they're driving illegally, because I'm more focused on the impact of what is happening to poor communities that are already snowballing and don't have enough income to pay basic rent, and now they're trying to figure out how to pay their child support and everything else. I just want them to be able to wait to do the driver's license suspension as a tool. And that is what the bill is getting at. That is my goal, and that is what I want to do, because the only reason why I brought this bill back is because in 2017, the same people who are opposing me now opposed me then, and it wasn't even the same trigger. And so now I'm trying to talk about the same issues that were present in 2010 that are still present in 2025, and they won't put that data on the record to actually show how many folks are driving with the restricted license, how many communities of color have been impacted by the data. I had data from 2012 to 2017. We then went and checked the data, and then it wasn't accurate that we had received for from 2017 to 2025. And that is why you can put this information out there and say, well, it's all about the money, but really it's about the tool. Do you have to do the driver's license suspension before you do any other tool that actually can go and get the money? So thank you for my closing comments. I will continue to talk to the people who oppose this bill, and we will figure out if we can work forward, because at the end of the day, there are 23 states that have a higher margin of a higher time period before they actually suspend the driver's license than Nevada, and they're doing just fine. Thank you.
Thank you so much, Senator Neal. At this time, I will go ahead and close the hearing on Senate Bill 390 and thank our co-presenters. And we will move on to Senate Bill 330. This bill revises provisions relating to facilities for skilled nursing. And I believe Mr. Anderson will be presenting this, so if they can come forward. I think he's joining from Southern Nevada. And please begin when you're ready, sir.
Thank you, Chair, Vice Chair, and members of the Committee of Health and Human Services. My name is Lex Anderson, L-E-X-A-N-D-E-R-S-O-N, also on behalf of Senator Neal. I'm a Nevada resident of some 40 years. I appreciate having the opportunity to take a couple of minutes to comment on SB 330. I'm a retired registered nurse with some 45 years in the nursing and medical field. With that, I believe I bring a resume of operational and administrative understanding directly related to the topic. My objective is to have the word inpatient included in NRS 4490039 as a legal qualifier for skilled nursing home identity and professional services being offered. Why did I submit this application? Over the past 10 years in Las Vegas, we've had some agenda application items that use our local convalescent care facility and nursing home ordinance for land use project zoning justification. In Las Vegas, inpatient skilled nursing facility nursing homes are designated for residential land use zoning. Also, outpatient group homes with a census of over 10 are now identified as inpatient nursing homes. With this, these agendas resulted in very problematic planning and city council application deliberations and their outcomes. It was clear to me that the ordinance needed some more professional definition to prevent further problematic agenda applications and needed a professional and legal solution to prevent outpatient group homes being identified as institutional inpatient skilled nursing homes. The medical term of patient is legally and professionally defined only in two ways. Patients are either inpatients or they're outpatients. I realize that the NRS omitted the one very defining nursing facility qualifier word of inpatient in the statute. Going through the NRS, I noted that occasionally inpatient and outpatient status was being used to be precise in defining a facility for patient administration, patient admission, discharge, or patient care requirements. All that's being asked is to include the one-word professional and legal qualifier of inpatient status in NRS 4490039, Facility for Skilled Nursing, as our statutory reference and for ordinance authority. The following is a list of reasons why the single word of inpatient needs to be included with NRS Skilled Nursing Statute, Facility Statute. It tells you what kind of a facility the building is. It tells you what kind of a facility the building is not. It tells you what kind of patients are in it. It tells you what kind of patients are not in it. It tells you that the facility is not for outpatient care. It tells you that the facility has institutional status. It adds professionalism to the NRS. It adds the legal status of inpatient identity to the NRS. It helps to prevent errors being made by non-medical people and creating local ordinances. It gives the NRS wording of professional, continuous, inpatient skilled nursing everything it needs for a complete understanding of skilled nursing facility. It reinforces that skilled nursing facilities are in fact hospitals with 24/7 institutional inpatient care. And lastly, it helps the U.S. government with its annual effort to instill the importance of everyone understanding inpatient and outpatient status and skilled nursing care with its annual U.S. government Medicare Handbook, Medicare and You publication. And this year it's on page 2728, 2025. So with this, I thank you for the opportunity to speak on SB 330 and to present how this one-word qualifier and the NRS can present a more professional and legal definition for skilled nursing facilities. Thank you very much.
Thank you so much, Mr. Anderson. Committee members, any questions? I don't think we have any questions at this time, and so for the sake of time, we'll go ahead and open it up for testimony. So if you want to take a step back, we'll have folks come forward. If you would like to testify in support of Senate Bill 330, please come forward. You may begin.
I'm Max Lowe again for the record. I strongly support SB 330, which clarifies the definition of facility for skilled nursing in Nevada's healthcare regulations. This bill ensures that facilities are explicitly recognized as inpatient settings, providing continuous skilled care under a physician's direction. A clear standard definition is essential for proper licensing, regulation, and quality assurance in skilled nursing facilities. It helps protect patients who require ongoing medical support, ensuring they receive appropriate care in the right setting. By passing SB 330, we strengthen Nevada's healthcare system, improve oversight, and safeguard the well-being of vulnerable patients. I urge you to support SB 330. Thank you.
Anyone else here or in Las Vegas? AVH, is there anyone online in support of the bill?
If you'd like to testify in support on SB 330, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move on to opposition testimony. If you're opposed to this bill, please come forward. And we'll begin here in Carson City. Please begin.
Thank you, Senator Doñate and members of the committee. For the record, I'm Brett Salmon with the Nevada Healthcare Association, and our association represents assisted living and skilled nursing facilities throughout the state. Currently, we are in opposition with this bill because it impacts the operations of our nursing facility members, and I appreciate the interaction that I've had today with Senator Neal back and forth with some emails, and I've told her that we're happy to have conversations after this committee hearing to try to resolve our concerns. The first concern that we have is that nursing facilities provide inpatient services, but they're not inpatient facilities. Hospitals are those type of facilities. And nursing facilities provide both inpatient and outpatient services. So Medicare Part A is the regular stay that you would have after you're in a hospital, and once you're discharged from the hospital, services that may be provided back at the facility are Part B services, which are outpatient services. And so nursing facilities do provide those services. And so by putting the definition inpatient into the definition of facility for skilled nursing, it excludes outpatient services, which we currently provide. So that obviously is a concern to my members. And I can relate to Mr. Anderson's concern. In my previous life, I worked for a large assisted living company. And depending on this, we were in 35 states. And depending on where you were, things get zoned, and there's ordinances that would allow you in one state that don't allow you in another. And so it seems like this is more of a zoning concern than it is a statutory concern, and we're looking to be helpful that way if we can come up with ways to try to help Mr. Anderson on that front. And thank you for your time.
Thank you, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. 7 of our critical access hospitals operate distinct part skilled nursing facilities. And in addition to Mr. Salmon's comments, I have concerns that this bill brings about some unintended consequences where so many places throughout the Nevada revised statutes rely on that definition or point to that definition in 449.0039 currently. So we do have some concerns with this bill, and we'll continue to work to try to get those resolved. Thanks.
Thank you so much. Anyone else? Seeing none here or in Las Vegas AVH, is there anyone online?
If you'd like to testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you so much. Anyone in neutral on this bill? Seeing none here in Las Vegas AVH, is there anyone online?
And to testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. Senator Neal, any closing remarks?
Yes, thank you, Senator Donyate. I want to thank the committee for hearing this bill. This is Mr. Anderson's first time testifying. As you guys know, in Senate District 4, I'm very close to the constituents in this district. This has been a long-standing issue that we've been trying to seek a solution for. I'm glad that the opposition feels that they can offer something that might be able to get to the core issue of the ordinance that really went against the will of the community. And they've been fighting this for over 10 years. And it is of deep interest to try to get this solved. And so I thank the committee for hearing this bill and listening to the concerns of the rural community that I actually have in the top part of my district.
Thank you so much, Senator Neal. It's always a pleasure having you. I'll go ahead and close this hearing, and thank you, Mr. Anderson, for joining us. And then I will go ahead and open the hearing on our last and final bill, which is Senate Bill 378, and we'll turn the gavel over to our Vice Chair again.
Okay, thank you, Chair. Our last bill of the evening, Senate Bill 378, makes revisions relating to health care. And before us, we see our chair, and I think you have a co-presenter. Chair, go ahead when you're ready. Thank you.
Thank you so much, Vice Chair. And again, good afternoon to the members of the Senate Committee on Health and Human Services. For the record, my name is Fabian Donyate, and I represent Senate District 10. Today, I come before you to speak on Senate Bill 378, a bill that will improve the provider-to-patient transparency and regulate emergency medical centers. And today, I'm proud to be joined by my second intern. This is Fernanda, and she will present the content of the bill for you.
Thank you, Senator Donyate and Vice Chair, and good afternoon to members of the Senate Committee on Health and Human Services. For the record, my name is Fernanda Ramos, Fernanda Ramos, and today we'll go over the bill language, background, national trends, and key provisions of this bill. SB 378 is an act relating to healthcare, revising requirements governing electronic maintenance, transmittal, and exchange of health information. It establishes a program to increase awareness of information concerning independent centers for emergency medical care, requiring certain facilities that are owned or operated by or otherwise a part of hospitals to be licensed as independent centers for emergency medical care, requires an independent center for emergency medical care to provide urgent care services under certain conditions, prohibiting a non-competition covenant from applying to a physician, and requiring a custodian of health records to furnish health records within a specified period of time and without charging a fee under certain circumstances. Since the COVID-19 pandemic, the Pew Research Center has reported a significant decline in trust among patients, providers, and government health officials. As shown in the figure above, the Centers for Medicaid Services and state, local public health officials rank among the lowest trusted sources for Americans. The provider-patient relationship is fragile, with experts attributing the erosion of trust to several factors, including perceptions that providers prioritize financial interests over patient care, that the government fails to uphold integrity, and that there is a lack of transparency regarding patient medical records. These concerns about trust are well-founded. Taxpayers lose over $10 billion annually to Medicare and Medicaid fraud, according to estimates from the National Healthcare Anti-Fraud Association. Provider-induced fraud takes many forms, including billing for a higher-level office visit, falsifying time-sensitive services, billing for a major procedure instead of a minor one to receive higher reimbursement, and submitting false claims for inpatient care when outpatient services were rendered. Of relevance to this discussion is upcoding, a practice that inflates emergency department costs, already one of the most expensive aspects of healthcare. This leads us to the key provisions of this bill, as they are intended to restore integrity in the healthcare system. Sections 27 and 28 of SB 378 on Medicaid fraud focus on Medicaid fraud, establishing procedures for verifying claims and reviewing the appropriateness of services provided under Medicaid. By ensuring that services are essential and adhere to set standards, these provisions aim to improve oversight and accountability within the Medicaid program and lower the risk of fraud. Moving forward, we want to highlight the phenomena of freestanding emergency departments. Consider the case of Mr. Zhang. He visited Parkland Health's Urgent Care Emergency Center, expecting the lower costs typically associated with urgent care. However, he was later billed a $500 emergency room copay for each of his 2 visits. The reason? Despite its name, the facility operates under a freestanding emergency department license, subjecting patients to emergency room level charges. Freestanding EDs provide services comparable to hospital emergency rooms and are often presented as solutions for healthcare access gaps. However, they tend to be located near hospitals and commercial centers rather than in underserved areas. Their steep charges are largely driven by substantial facility fees, comparable to those of hospitals, despite lacking the same level of resources and infrastructure. Please refer to the table above for a comparison of the costs associated with common diagnosis across freestanding emergency departments, hospital emergency departments, and urgent care centers. As you can see, they are ranked by frequency, percentage of all visits, and mean prices of the most common diagnosis by provider type. And in most of these, that you can see that the freestanding emergency departments charge more. It is difficult to isolate data on upcoding practices by freestanding emergency departments in Nevada, as they operate under acute care ER licenses. To promote transparency, the following provisions aim to improve freestanding EDs tracking, ensure that they are addressing access gaps as intended, and verify that they consistently provide urgent care services. To avoid cases like that of Mr. Zhang, the Department of HHS is also instructed to create a public awareness program that guides them in selecting their facility for urgent care. Additionally, Senate Bill 378 aims to revise healthcare regulations, particularly focusing on the electronic maintenance, transmittal, and exchange of health information to ensure simply that patients can access their records in a timely manner. Senate Bill 378 reflects changes that aim to improve healthcare accessibility, transparency, and patient care in Nevada.
Thank you so much, Fernanda Fabian Doñate, for the record. Just to wrap up what we're talking about today, as Fernanda illustrated, I think what we're noticing over the last few years is that historically, right, in terms of the data that we receive for our constituents and nationally, there has been a national trend towards a distrust in healthcare. And a lot of that precipitates from the frustration that patients often get of, well, I went to 20 minutes at this doctor's appointment or 20 minutes in this department, and I end up getting a bill of $15,000. Does that equate to the level of service that I received? But fundamentally, right, I think there's been cases where the truth is not being stated in terms of, are we actually providing access to care for many of these individuals in these cases, right? We have seen cases, egregious cases, of providers upcoding or coding cases in general, specifically in behavioral health, where the largest portion of Medicaid fraud is existing. And so this portion. The meat of this bill is specifically tailored towards allowing our Medicaid office to be able to investigate into those claims so that we can actually go after those bad actors, because ultimately that's a repercussion that affects all of us, because it leads to the distrust in terms of how people not just trust our government, but also trust their healthcare provider. And furthermore, obviously we've seen the issue of freestanding EDs. We worked on this last legislative session, but unfortunately we're still seeing issues on the ground with patients who believe that they're receiving access to care, but that's not true. There are non-life-threatening cases that are being administered at these freestanding ERs under the false premise that individuals are receiving access to care, not realizing that they still have to be transferred to another facility if it escalates to that point. And you may hear the argument that there are freestanding ERs that are in Las Vegas that are being stood up in high needs areas. That is the case for some hospitals. I would agree to that testament. But then if that's also the case, then why are they standing freestanding emergency rooms across or down the street from a hospital system? Does that really improve access to care, or are we trying to navigate and slurp up, I guess, if that's a word to use, patients that are in high commercial areas where we understand they're commercially insured, to try to take them and essentially send them back to the mothership versus providing the actual care that they need, which is a true hospital system. And so that's kind of the rationality of why we're here today, and we're happy to answer any questions specifically on the bill. Thank you.
Thank you, Chair. We'll go right to Senator Titus.
Thank you, Madam Chair. And again, thank you again for looking out for your neighborhoods. I'm concerned about the bill. I appreciate you bringing it forward, but my question is related to certificate of needs in the healthcare realm. Before you can build another helicopter pad, another hospital, et cetera, I was under the impression that you had to have a certificate of need.
Thank you so much, Senator Titus Fabian Nuñate, for the record. So, excellent point brought up on certificate of need. It is my understanding that currently certificate of need only applies in the instance of rules. And specifically, we were scared that private equity or certain industries would come in, take over the practice, et cetera, and could potentially cut contracts, right, disseminate the access to care because of the financial interests of folks that don't live here making decisions for the constituents. This is not a certificate of need program. What I'm saying in this particular part of the legislation is that they have to be a certain distance away from what we already have in terms of our current infrastructure. And the rationality for it is because there's this conversation that you'll hear later today that we are opening up freestanding EDs in access to care for communities where we cannot invest in opening a hospital system. But if that's certainly the case, then again, I go back to the argument, why are we opening them across the street or down the street from a hospital system? Does that actually solve the relevance of access to care? I would argue not, because many of these cases are non-life threatening. If we really truly want to improve access to care, then that starts with the investment in essentially establishing the actual tertiary of healthcare delivery, which is investing in more urgent cares, which I would go and attest that there are some hospital systems that have invested in that. That is the appropriate model. But ultimately, right, the rationality as to why these gaps exist is because these institutions are refusing to invest in primary care. That fundamentally is how we ensure people have access to care, and there's a level of severity that treats it. But a freestanding ED down the street from another hospital system doesn't solve that. And so that's why we're saying that for any of the future ones that are built, that we should take in consideration and prioritize the areas that are missing one versus doing a market effort that clearly does not address the needs of the community.
Thank you, Senator. Seeing no other questions from committee members? Okay, Chair, thank you so much. We'll ask you to step back, you and your very capable intern. Great job. Thank you so much. And we will open up the hearing for support testimony. I knew that. I was waiting. All right, come forward if you I see people rushing up. That's great. If you're in Las Vegas and you'd like to testify in support, then please come forward at this time as well. Please go ahead, make sure you state your name. We're going to have 15 minutes, 15 minutes, 15 minutes. You know the routine, so we can go ahead and get started.
I'm Max Lowe again. I strongly support SB 378, which strengthens Nevada's healthcare systems by improving access, transparency, and efficiency. This bill ensures patients receive timely access to their health records, eliminates restrictions on non-competitiveness clauses for physicians, and enhances the regulation of emergency care facilities. By requiring the same electronic exchange of health information, SB 378 modernizes patient care with maintaining confidentiality. Additionally, ensuring independent emergency centers operate under clear licensing guidelines increases access to urgent care, particularly in underserved areas. Removing non-competitive clauses for physicians promotes healthcare access by allowing providers to serve when they are most needed. This bill is a necessary step towards a more patient-centered, accessible, and efficient healthcare system. I urge you to support 378. Thank you.
Thank you, Mr. Lowe. Please go right ahead.
Good evening, Chair and Committee, Vice Chair and Committee. My name is Sabrina Schnur. I am with the Nevada Psychiatric Association this time, SABRINA-SCHNUR. Forgive me, I left my phone behind, so I will read from my watch. Nevada Psychiatric Association supports sections 1 through 6 specifically related to electronic health records, and we want to thank the sponsor for bringing this bill. Thank you.
Thank you so much. Pretty good from your watch. Please go ahead.
Vice Chair, members of the committee, my name is John Abel, Johnabel. I represent the LVPPA and the LVMPD's Health Trust. I'm a board member there. We support this bill because it saves us money. I'm a fiduciary of our health trust. We have a finite amount of money, and it's always our job to make sure that we're saving the most amount of money while also ensuring we give the most amount of care. So that's why we support this bill. Thank you.
Thank you so much, Mr. Abel. Please go ahead.
Good evening, Vice Chair Taylor, members of the committee, Joanna Jacob on behalf of Clark County, here in support of the bill. Clark County is a member of the Health Services Coalition and will concur with the comments of especially the first testifier. We are in support of the bill. Thank you.
Thank you, Ms. Jacob. Please go ahead.
Good evening, Chair and members of the committee. For the record, my name is Eduardo Escoto, Eduardo Escoto, and I am the Secretary Treasurer for USCW Local 711. I strongly urge the committee to support SB 387. Thanks.
378, but it's close enough. Okay, it's all right. Thank you so much. Please go ahead.
Good evening, members of the Chair and Committee. My name is Dion Klug, Dionneklug. I'm a member of USCW Local 711 in Las Vegas, and we strongly urge you to support SB 378.
Thank you, Ms. Klug. Seeing no one else in Carson City, we will go to Las Vegas. Do we have support testimony in Las Vegas? I see two people sitting there. Please go right ahead. State your name for the record.
My name is Stacy Sasso, Executive Director for the Health Services Coalition. The coalition is comprised of 27 employer and union-sponsored self-funded health plans in Southern Nevada, many who were here today. Collectively, we represent over 300,000 lives. While many of our members are here to testify in support today, others were unable to attend as it's difficult for people to come in person. We're in strong support of SB 378 today. We supported similar legislation last session without success, and we urge this body to create measures to balance what has only become a larger problem with no constraints on hospitals. Over the last few years, hospitals have rapidly built freestanding emergency rooms, often up the street from competitors and not in areas of need where ER access is scarce. We see no rationale for having ERs less than 5 miles away from one another. FSCDs are small, usually single-story buildings associated with a hospital from a licensure standpoint, but to a patient, they look like an urgent care center. It's possible that many of you or your family members have had the same experience as our members in seeking care. Requiring the offering of urgent care in these facilities is going to help reduce costs to Nevadans. A patient should be triaged and appropriately billed for the level of care in which they need it. I think we can all agree an upper respiratory infection should not warrant an ER bill, and that is a frequent diagnosis for ER visits. Patients seek care in an ER because they have nowhere else to go in the middle of the night or because they don't understand where care can be provided at an appropriate level. This results in higher cost share than if they would have gone to an urgent care. When a patient accesses care at these facilities, thinking they can be treated, if they need a higher level of care, they're placed in an ambulance and transported to a larger hospital, and the patient could be responsible for an ambulance bill as well. Separate licensure is needed so the state and payers can clearly understand what is happening with the patient. In addition, these are separate freestanding facilities from the hospital and should be treated just as that, separate. Finally, SB 378 expands work done in the 2023 session under AB 7. Patient access to records is important. This should not be done in a private repository and should allow the patient access to their information and ability to direct where it goes. Direct access to records is what will help improve coordination of care, including that for our state's children. We urge this committee to support SB 378. Thank you.
Thank you so much. I think there's someone else down in Las Vegas. Please go ahead, state your name for
Hello.
the record. Go ahead.
Hello, Madam Chair and members of the committee. My name is Pablo Leos, Pablo-Leos, and I'm the Vice President of Local 797 for the Plasters and Cement Masons. We have over 1,200 members in the state of Nevada, mainly in Clark County and Carson City. And we urge you to support the SB 207 for the benefit of our members. Thank you.
Thank you, Mr. Leos. Go right ahead when you're ready.
Good evening, Vice Chair, members of the committee. For the record, my name is Michael Giddings, Michaelgitings. And I concur with the comments made by earlier supporters of this bill. And I urge you, the committee, to support SB 378. I can tell you a story about one of our members a few years ago who was suffering from abdominal pain and was looking for, to go get taken care of on an emergency basis. And when he saw one of these freestanding ERs, he thought that was a good idea to go to that facility. It turned out that he did have some serious medical issues. They thought that it was his gallbladder. Unfortunately, they couldn't do anything about it at the freestanding ER, and they had to put him in an ambulance and transport him to a regular hospital. That resulted in extra expenses, including the expenses at the freestanding ER and the cost of the ambulance. So that's just an example of what we've seen with these freestanding ERs. Thank you.
Thank you, Mr. Giddings. Please, who's next? Go ahead.
Good evening, Chair and members of the committee. For the record, my name is Wendy Cardenas, WENDY-CARDENAS, and I am Vice Chair of UFCW 711. I strongly urge the committee to support SB 378. Thank you.
Thank you so much. Please go ahead. If you've made your public comment, please step back so others may come up if they like to. If there's anyone else in Las Vegas who'd like to testify in support of 378, please come forward at this time. Okay, go right ahead.
Good evening, Chair, members of the committee. For the record, my name is Yuvia Grant, LLUVIA GRANT, and I am Vice President of the UFCW 711. I strongly urge the committee to support SB 378. Thank you.
Thank you, Ms. Grant. Not seeing anyone else in Las Vegas, we will go to the phone lines. AVH, do we have any callers in support?
To testify in support, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 805, please press star 6 to unmute yourself. Once again, caller, you are unmuted.
Hi, yes. I'm sorry, am I unmuted?
Yes, go ahead.
Hi, yes, my name is Tamara Jameson. That's Jamison. Excuse me one second. I'm so sorry. I'm in support of the bill, and I am strongly encouraging the committee to support SB 378. And also, I want to say hello to the committee and all the members. Thank you.
Thank you so much. Do we have another caller, AVH?
Hi, Vice Chair, committee members. This is Todd Inglesby, President of Professional Firefighters of Nevada. Sorry I couldn't be there in person. I firsthand have seen the negative impacts on proliferation of freestanding emergency departments. These facilities are problematic for several reasons. First and foremost, freestanding EDs are expensive for patients. Many patients do not realize these facilities typically charge the same as hospital EDs, but without the same level of service and resources. This can lead to significant financial hardships to patients who seek care at freestanding emergency departments, thinking it will be more affordable. Additionally, freestanding emergency departments can be confusing for patients. Many patients are not aware of the difference between a freestanding emergency department and an urgent care, and many mistakenly seek care at a freestanding emergency department for non-emergent conditions. These can lead to unnecessary utilization of resources and increased healthcare costs. Lastly, freestanding EDs often provide a lower quality of cost of care. These facilities may not have the same level of expertise or resources as a hospital emergency department, leading to subpar care. And in Southern Nevada, we as emergency providers cannot even transport to these facilities unless a person is basically not sick, unless their vitals are all within normal range. Well, we're taking people to emergency departments because they're sick. They need help. I think these emergency departments or freestanding EDs are very, very complicated and confuse our patients and our citizens that we have, especially in Southern Nevada. Thank you, and I hope you support this legislation.
Thank you so much. Next caller, please.
Good evening, Madam Vice Chair and members of the committee. My name is Renee Ruiz, Renee. Last name is spelled Ruiz. I'm with National Nurses United, National Nurses Organizing Committee of Nevada, and we represent the interest of 3,000 plus RNs in the state of Nevada. And I would like to express that we agree with everything that folks have previously said regarding SB 378, and we are in full support. We believe in access to healthcare, continuity of healthcare, and transparency of cost of healthcare. Thank you.
Thank you, Ms. Ruiz. Next caller, please.
Hello, Chair and members of the committee. For the record, my name is Susie Martinez, and I am the Secretary Treasurer of the Nevada State AFL-CIO. I'm calling in full support of the bill. I would like to thank the bill sponsor for bringing so much attention to this very, very important bill. And again, we are in full support. Thank you.
Thank you, Ms. Martinez. Are there any other callers, AVH?
Yes, Chair, there are. Please stand by.
Hi, Chair and members of the committee. For the record, my name is Liz Sorensen. I'm the president of the Nevada State AFL-CIO, and I am in full support of SB 378, and I urge this committee to do the same. Thank you so much.
Thank you, Ms. Sorensen. AVH, any other callers?
Yes, Chair, one more caller.
Hello, Chair and committee. My name is Beverly Williams, Williams. I am with Teamsters Local 986, and I am in full support of SB 378. Freestanding emergency rooms are popping up all over Las Vegas. As a trustee for our trust fund, we are having to educate our members on the difference between the freestanding emergency rooms and the urgent care facilities. Our members are not realizing that they are not at a urgent care facility, but an emergency room facility. It's only until they receive their bill that they realize that they are not that they are in an unauthorized facility. We are spending extra dollars to communicate and show actual pictures and the differences in the facilities. When an individual is in need of emergency services, they are not paying attention to the facility name. So there needs to be separate licensure is needed. please support SB 378. Thank you.
Thank you so much. AVH, do we have any other callers?
There are no more callers in support at this time.
Thank you so much. Now we'll open it up for opposition testimony. Opposition, please come forward. If there's anyone in opposition in Las Vegas, please do the same. We'll have 15 minutes for opposition testimony. We'll go 3 here, 3 in Vegas, 3 in the phone line, and just work it out until we're out of time. Please go right ahead when you're ready.
Good afternoon or good evening.
Is your mic on, sir? Okay, thank you.
My name is Patrick Kelly with the Nevada Hospital Association. I'd like to address Section 18 of the bill, which provides an independent center for emergency medical care with 2 options. It may either establish an urgent care unit within the facility or create a system based on the severity of the patient's condition to determine whether the patient receives emergency services or urgent care. Both of these options conflict with EMTALA. Under EMTALA, hospitals are legally required to provide a medical screening exam and stabilize patients who enter the ED. A triage intake is not the same as a medical screening exam. EMTALA requires that the screening be performed by a physician or qualified medical person utilizing ancillary services to determine if the patient has an emergency medical condition. An ED cannot simply conduct a brief examination and redirect the patient elsewhere for care. Additionally, Section 18 also proposes a pricing system in which ED patients would pay rates similar to those at urgent cares. This proposal overlooks the significant differences between EDs and urgent cares. EDs have specially trained medical professionals who specialize in managing serious medical events such as cardiac emergencies and trauma. Urgent cares do not. EDs are also equipped with advanced diagnostic imaging and medical equipment, which urgent cares generally lack. In conclusion, Section 18 conflicts with federal EMTALA regulations by proposing a triage system that doesn't meet the legal requirements for medical screening exams. It also fails to recognize the significant cost differences between EDs and urgent cares. Also want to thank the sponsor for meeting with us and having very good discussions on this bill. Thank you.
Thank you, Mr. Kelly. Please go ahead.
Vice Chair Taylor, members of the committee, Connor Kane representing HCA Healthcare, which includes Sunrise Hospital and Sunrise Children's Hospital, our state's largest safety net hospital, here today in opposition to Senate Bill 378. Sunrise Hospital and Sunrise Children's Hospital take immense pride in caring for patients on the east side of Las Vegas, and we share the sponsor's desire for access to care for every member of our community in Las Vegas. I do think it's important to share, and you heard this previously, that we did make changes to address concerns proponents had going into last session in Senate Bill 348. And we've been willing to work with proponents of the bill throughout the interim to address any potential concerns regarding freestanding emergency departments since last session. And over the past year, multiple meetings have been canceled by the proponents where any potential issues with these facilities could have been discussed before legislative changes. We are seeing that people are using our freestanding emergency departments appropriately. And I would say for someone like me, I have 3 young children, 3 wonderful, beautiful, precocious young children who are constantly hurting themselves, constantly getting sick, and constantly needing health care. I have an aging father and I have aging in-laws, and I am really, really happy that we have these access points in our community. With respect to the bill as written, SB 378 conflicts with federal emergency medicine requirements, EMTALA, and will reduce access by limiting new facilities based on geography alone. We know our community is growing and we need additional healthcare access. Last year, Sunrise alone saw nearly 190,000 visits in the emergency department, making it one of the busiest emergency departments in the entire country. Emergency care is a vital need in every community and continues to grow year after year in Las Vegas as our population continues to increase. Freestanding emergency departments alleviate the overburdened emergency rooms and reduce wait times in periods of surge demand, such as during severe flu season, as we have seen this last year. When people are sick or have something going on that's concerning to them, they should not be put in a position where they're expected to self-diagnose in possible emergencies before seen by a medical professional. Patients may put their health in jeopardy by avoiding or delaying emergency care if they do not have timely and appropriate care accessible to them, like at a freestanding emergency department. And I would just add, and you heard this from Mr. Kelly.
Mr. Kane, I'm sorry, your time is up, sir.
We look forward to continuing to work with the sponsor. Respectfully, do not think this bill seeks to help address access to care that we're facing in Nevada. Thank you.
Thank you so much. Please go right ahead, and then we'll go down to Las Vegas.
Good evening, Madam Chair, Vice Chair, excuse me, members of the committee and staff. For the record, my name is Rick McCann,
I'm losing my voice, and I'm here today, or tonight, representing Healthy Nevada to oppose SB 378. Healthy Nevada is the state's only certified, nonprofit, statewide health information exchange. In emergency medicine, for example, seconds count and an accurate diagnosis is critical. Whether a medical professional is responding real time to a public health agency like COVID-19, or transporting a trauma patient to a hospital via a life flight, swift access to critical patient information saves lives, period. A health information exchange, or an HIE, provides immediate access to a patient's information, including previous treatments, allergies to medications, diagnoses, lab results, medical imaging, previous pain medications or substance abuse, and mental illness. Despite the rapid advancement of electronic information in almost every other part of our lives, patient medical records are still too often on paper and stuffed into file cabinets or shared via fax machines. Section 5, particularly Section 5 of SB 378, is just the latest attack in a long line of attacks and proposes to further weaken and support the support for HIEs and further eliminate their use. Why? Why is this the case? Who is threatened by this process of having this available information? Who wants to sacrifice patient care, and why do they want to do it? I don't want them to do it. I don't think injured or dying police officers or firefighters do. I don't think children or their parents do. I don't think the elderly do. I don't think patients with language barriers do. So why is this bill not allowing HIEs to be used in the future? Oh, by the way, there's a series of opposition letters on Nellis, about 9 or 10 of them. One of them is from Nevada Orthopedic and Spine. Those are the fine folks that did my lower back fusion 12 weeks ago. They happen to be one of the founding members of HIE.
Mr. McCann, your time is up, sir.
I just want to give them a plug.
Okay, but
they did a great job.
Okay, public comment. Public
Further
comment. You give that.
Final comment. I
Public
respectfully request that you oppose SB 378. Thank you for the privilege of your time.
Thank you so much. Then we're going to go down to Las Vegas, and then we'll go to the phone lines and back here. In Las Vegas, please go ahead when you're ready. State your name for the record.
Vice Chair and members of the committee, Samantha Barnes, on behalf of Comprehensive Cancer Centers of Nevada, the largest independent community-based cancer treatment provider in Southern Nevada. While we appreciate the bill's goal of promoting healthcare accessibility and transparency, its blanket prohibition of non-competition covenants for physicians, including those with ownership stakes, presents serious risks to the stability of physician-owned practices. Physician-owned practices require significant investments in training, infrastructure, and long-term strategic planning. Non-competition agreements help protect these investments, ensuring stability in patient care and the continued success of independent practices. In specialized fields like oncology, continuity of care is critical. Disruptions caused by unrestricted physician movement could negatively impact patient outcomes. We urge you to consider a more tailored approach that differentiates between traditional employment models and physician-owned practices. We did submit a proposed amendment, which is available on Nellis. We appreciate the sponsor and will continue to work with him on this. Thank you.
Thank you, Ms. Barnes. Go ahead down to Las Vegas.
Good evening, members of the Senate Health and Human Services Committee. My name is Dr. Angela Mosby, and I'm the Market Medical Director with Care Now Urgent Cares, speaking in opposition to Senate Bill 378. Las Vegas has an established shortage of primary care providers, which causes patients to rely on urgent care for initial evaluation with referral to an ED when a higher level of care is needed for continuity of care. Care Now currently operates 19 urgent cares, including one 24-hour location, and will expand to 22 locations by the end of the year throughout Las Vegas, including into areas with limited access to care. Urgent care and emergency care, however, are very different, and both are needed in our communities. The difference between an urgent care and emergency room: urgent cares can see non-threatening life situations, including abdominal pain, wheezing, shortness of breath, respiratory illnesses, urinary tract infections, sprains and strains, and small cuts that require stitches. Freestanding EDs offer advanced imaging, urgent lab work, IV therapy, life-threatening situations, ability to administer life-saving medications to stroke, sepsis, and heart attack patients, procedures to reset bones or cuts that require invasive, extensive stitches, suspected poisoning, drug alcohol overdose, head injuries, concussions, severe headaches, dizziness, confusion, seizures, trouble breathing, and severe allergic reactions, in addition to other severe illnesses. Limiting freestanding EDs will reduce access to care in areas with limited services. Oftentimes, people who need emergency care come to urgent cares because they fear the wait will be long at the emergency room. But urgent care is not always the appropriate place for their condition to be treated, and we have to send them to the ER regardless, which just means that their treatment has been unnecessarily delayed. Freestanding EDs are helping to alleviate the wait times at emergency rooms and help us to direct patients to the appropriate level of care when it is beyond our capabilities at the urgent care. I strongly urge you to oppose the changes related to FSEDs in SB 378. Thank you.
Thank you, Dr. Mosby. One more down in Las Vegas, please go ahead.
Good evening, members of the Senate and Health and Human Services Committee. My name is Lindsay Pinafel. That's Lindsey Pinapfel, and I'm a resident of Las Vegas. I strongly oppose Senate Bill number 378. Recently, my nephew Carson, a 3-year-old, split his head open at daycare, and in panic, I rushed him to the ER at Aliante. It's a standalone emergency room just down the street. Dr. Patel, Nurse May, and Linda, who also work at the main sister hospital, provided exceptional care, quickly treating his serious head wound and easing my stress. Their proximity was life-saving, and if I would have gone to an urgent care, I would have wasted valuable time, as they can't stitch a wound that size, and I would have been sent to a closer emergency room, which would have also not been convenient. Standalone emergency rooms are not just a luxury, they are a vital cornerstone of our healthcare system. They provide swift, efficient care, ease the burden of overcrowded hospitals, and most importantly, save lives. Having witnessed firsthand the strain on our healthcare system and personally benefited from the services of a standalone ER, I strongly urge you to support their expansion and greater accessibility. Our community deserves better healthcare options, and standalone ERs are a critical step towards ensuring that access. I encourage you to visit an emergency room, whether to support a loved one or better yet, as a patient yourself. Spend time in a busy ER and then come back and tell me that standalone emergency rooms are unnecessary. I believe you'll come to realize how essential they truly are, and I thank you for your time and your consideration.
Thank you so much. We're going to go to the phone lines, and then we'll come back here. We have about 5 minutes left. So, AVH, is there a phone line? Someone on the phone line?
To testify in opposition, please press star 9 on your phone to take your place in the queue.
Hi, this is Peter Guzman, president of the Latin Chamber of Commerce. Today, my hope is, and our hope at the Chamber, is that all parties will get back together to provide a better outcome for this bill, because currently we believe that hospital emergency room overcrowding leads to long wait times. We know it's happening now, and it delays access to care. The freestanding emergency room model allows Nevadans to receive critical care. We're also finding more and more at the Chamber that small business owners that are contemplating a move, they're actually asking about healthcare. They're asking about what is near them when they decide where to put their business. And so I just hope that we could come with a better outcome. So at the moment, we are in opposition. Thank you.
Thank you, Mr. Guzman. Next caller, please.
Caller, you are unmuted and you may begin.
Hello, my name is Alan Katz, Associate Director of Advocacy and Public Policy for Civitas Networks for Health. Thank you to the committee for the opportunity to speak. Civitas is the National Trade Association for Public and Nonprofit Health Information Exchanges and other types of nonprofit organizations that use health data. And our membership includes more than 60 health information exchanges in almost every state, including Healthy Nevada, which has been in operation for over a decade and is the only HIE in Nevada that's actually certified by the State Department of Health and Human Services under the current Nevada Administrative Code regulations, including the regulations requiring informed and affirmative patient consent. Connects more than 150 hospitals, clinics, payers, and public health authorities of every size and in every corner of the state. The secure network that Healthy Nevada has built in partnership with these stakeholders increases productivity for providers, cuts red tape, improves outcomes for patients, and lowers costs for the entire health system. And so with that preface, I would like to say that while SB 378 has a number of a whole range of different elements, Civitas Networks for Health is opposed to the bill in its current form, specifically because of the language in Section 5, subsection 3 of the bill that would sort of counterintuitively make health information exchanges, which in practice is Healthy Nevada because it is the only certified health information exchange in the state, make health information exchanges unable to fulfill the health information exchange requirements for providers and other current entities under current law. And by doing this, the bill as written with this provision in Section 5 would effectively force HIE participants and much of Nevada's infrastructure to use what's called patient-directed
Mr. Katz, Mr. Katz, your
Yes.
time is up. Would you mind wrapping up, please?
Yeah. So the model that this section that this language in the bill would impose on HIEs in Nevada
Mr. Katz, we're going to have to jump off for another caller. Mr. Katz, we're going to have to jump off. If you have other comments, please just send them in, email to our committee secretary, and then we will all get them. Thank you so much for calling. Who's next, AVH?
Hello, good evening, Chair and members of the Committee on Health and Human Services. I am Dr. Casiano Flaviano, C-A-S-I-A-N-O, F-L-A-V-I-A-N-O. I'm a physician informaticist for the Dignity Health Las Vegas market and a practicing physician in the Las Vegas area for the past 25 years. Our practice sees patients in the clinics and the hospital, and I have direct experience in the shortcomings of incomplete medical information necessary for timely critical care of our patients. Our current record-keeping platforms vary from hospital to hospital, clinic to clinic. A central location for where providers can get timely information that they need to care for the patient in the ER, in the hospital, or in the clinic is of utmost importance. This will ensure a complete and accurate record that will support critical care decisions. SB 378, as it is written, would force many small providers to purchase expensive new EHR equipment to ensure its interoperability requirements. It denies integrated services like a health information exchange, which can afford cost-effective and timely dissemination of information. This is the common language that all EHRs would speak, and any provider can access the information in a very timely manner. Well, I cannot support SB 378 as is written right now, even if there are many laudable aspects. Thank you, Chair and Committee.
Thank you, Doctor. Okay, our time is up, and we've gone to everyone. So, unfortunately, we're just going to have to ask you to send your comments in if you're here in Carson or in Las Vegas. Thank you very much. 15 minutes for each, and we certainly want to be fair, and everyone gets the same amount of time. That was opposition, and now we'll go to neutral testimony. Is there any neutral testimony? Seeing none in Carson City and Las Vegas, we have some neutral testimony coming forward. Thank you so much. We will have 15 minutes for neutral testimony. Please start when you're ready.
Dear Committee Chair Dunyate, Vice Chair Taylor, and members of the Senate Health and Human Services Committee, my name is Chelsea Bishop. I'm the president of Act for Kids Nevada. I'm a registered nurse. I graduated from Brigham Young University and San Diego State University with degrees in public health and nursing. I'm here today to tell you it's extremely important for Nevada parents and their children to have a certified health information exchange that securely shares health information among providers, and one in which providers are encouraged to participate. In Nevada, children often see multiple subspecialists at different facilities, making it essential for their healthcare providers to share records as they provide care. My oldest passed away from stage 4 high-risk neuroblastoma, and my 3 other children have various health conditions, cerebral palsy, growth disorders, lasting effects from prematurity, among other things. I've experienced personally the fragmented health information system in Nevada and can tell you it does harm to patients. We look forward to more comprehensive healthcare in the future for pediatrics for Nevada. While the system of care is currently fragmented, the health data does not have to be. I'd be happy to share my own experience. If you have any questions, I'd invite you to do this, to ask, please. I do have concerns about Section 5 of SB 378, knowing it would harm Nevada parents and children by reducing rather than increasing the number of providers participating in a health information exchange. To have it proposed to remove the health information exchange as an interoperability solution, and that simply doesn't seem to make sense. SB 378 appears to rely entirely upon patient-directed record forwarding, which is incredibly difficult and not a substitute for real-time health information exchange. Doing this would lead to even more gaps in critical information, potentially putting children's health at risk, especially in emergency situations when getting all providers timely access to their medical history is so vital. This approach requires families whose providers are not on a health information exchange to bear the burden of managing and forwarding their own records. For providers, this means more administrative work and expense. It takes time and attention away.
Miss Bishop, I'm so sorry. Your time is up. So you want to wrap up, please? Thank you.
Yes. Thank you so much for your time, and I'd be happy to answer any questions. Thank you.
Okay, thank you so much. Who's next down in Las Vegas?
Hi, members of the committee. My name is Penny Eccles, Penni, Eccles, Echols. I am a mom to 6 daughters. I am a member of the board of Act for Kids Nevada and the vice president of the Charge Syndrome Foundation, which supports families and individuals affected by the rare genetic disease that my youngest was born with. And I'm here today to talk about the need for the right health information exchange in Nevada. I have here volume 1 of 4 of my daughter's health history. Even in a digital world, I attempt to keep medications, imaging, clinical visit notes in my possession. It's tedious and difficult to stay current, but it's handy, especially because she has so many providers. I urge you to reconsider how this bill is approached because as written, it requires families whose providers are not on a health information exchange to bear the burden of managing and forwarding their own records. This will put additional stress on families. When I'm at medical appointments, in emergency rooms or in preoperative waiting areas with my daughter, I want to be her mother. I want to distract her with games and stories, and I want to hold her close and snuggle away anxiety. I do not want to flip through a binder to provide health history notes. I do not want to provide imaging discs and make sure I get them back. I need to be her mom. This binder or the digital version of it that the current language of this bill would require me to create and maintain doesn't even help all the time because it's challenging for parents to ensure that they have the right information with them. I've been in the position where I did not have the information that was requested. I couldn't answer specific questions about an anesthesiology reaction at one hospital because all of her prior surgical care was delivered 4 miles away at a different hospital.
Miss Eccles, Miss Eccles,
yeah.
I'm so sorry. That's opposition testimony, and we're in neutral. We have to make sure we give
Correct.
every part the same. So neutral testimony only. I'm so sorry. I know you've been waiting.
Okay.
If you'll send your comments in to the secretary, she will make sure that the committee members get them. Thank you so much. Next down in Las Vegas.
Yep. Thank you. Michael Gagnon, GAG, NON. I am the Executive Director for Healthy Nevada, the only certified health information exchange in the state. Came here 7 years ago to help build an interoperability solution for the state of Nevada from actually Vermont, where I had helped build the health information exchange in that state and several others. Healthy Nevada is here to serve the public good. We are a nonprofit and have been operating with almost no state funds, but successfully operating a health information exchange that pushes data in real time across to every provider who is connected to us and provides a service that is invaluable to the state. The only thing I would say is I would ask you all and everyone listening to this testimony a few questions. How many different patient portals do you have? Have you ever tried to push data from those?
Mr. Gagnon, I'm so sorry. This opposition testimony, and we're in neutral right now, sir.
I'm just asking a question. I'm not saying anything negative about it. I'm asking you if you've ever tried to push data across from one patient portal to another. It's very difficult to do. And a solution, and what would you do in the case of an emergency?
Mr.
How would you
Gagnon,
do that
thank
if
you
were
so
having
much,
a
sir.
stroke?
Thank you so much. We appreciate it. We'll go to the phone lines. AVH, anyone on the phone lines for neutral testimony? If you have opposition, I'm so sorry, but we have to be fair to every side. So opposition testimony is over again. I am so sorry. We'll go to neutral testimony on the phone lines.
Testify in neutral, please press star 9 on your phone to take your place in the queue. Vice Chair, there are no callers in neutral at this time.
Thank you so much. Okay, we will come back to the no closing comments for the sponsor. Again, thank you everyone who testified. I am so sorry we can't listen to everyone as much as you'd like. I get it. I would love to, but 15 minutes to every side, and I really need to be consistent. We'll close the hearing down for Senate Bill 378 and turn it back over to our chair.
Thank you so much, Vice Chair. Now that the bills have been completely heard, we are now going to move on to the last agenda item, which is public comment. So folks can come forward and have any public comment. Again, it's a 2-minute limit. It cannot be relevant to any of the bills that we spoke to today. So is there anyone here in Carson City? I don't see any. We'll go to Las Vegas.
I'd just like to finish what I had said. Michael Gagnon, GAG-NON, for the record. The forwarding of
Mr.
patient
Gagnon,
records
before you begin, the comments cannot be relevant to any of the bills that were spoken to today, but you can speak more generally. So just want to make sure that that's clear.
Yep. If anyone on the committee or anyone would like to understand how health information exchange can save the state $153 million a year in repeat visits and whatever, I'd be happy to continue that discussion that we did as part of last session's AB7 regulatory committee called the Electronic Health Information Advisory Group that came up with solutions for how to do that. Thank you.
Thank you so much. Anyone else in Las Vegas? AVH, is there anyone online?
Participate in public comment, please press star 9 on your phone to take your place in the queue. Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much, and thank you everyone for coming to today's meeting. I know we had a very robust conversations, and I think we're going to keep doing this until the end. So we thank everyone for coming, and the meeting is now adjourned.